morning and welcome to the second Maternity and Child Health Congress. This is just an announcement that we will starting 9:30. Instead of 9 o'clock, we will start 9:30. I apologize for this one, but we are waiting Dr. Mariam to arrive, and due to an urgent issue, she will late 30 minutes. So we will starting 9:30. You can take your break until we start. Thank you.
Check, check, check 1, 0, hey. Check 1, hey, 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 check, hey, hey.
سعادة الدكتورة مريم آجلهنا الرئيس التنفيذي. Brother, can you take photo? بسم الله الرحمن الرحيم. سعادة الدكتورة مريم آجلهنا. الخدمات الصحية أصحاب السعادة.
Hela Hera.
بسم الله الرحمن الرحيم. سعادة الدكتورة أزهار نصيب، رئيس قسم الأبحاث السريرية والتعليم الطبي والتطوير المهني المستمر، نائب راعي الحفل. السيدات والسادة الأفاضل، حضورنا الكريم، السلام عليكم ورحمة الله وبركاته. يسعدنا أن نجتمع معكم اليوم في مؤتمر صحة الأم والطفل في نسخته الثانية تحت شعار بداية واعدة لمستقبل مثمر، والذي يقام تحت رعاية كريمة من سعادة الدكتورة مريم الجلاهمة، الرئيس التنفيذي للهيئة الوطنية لتنظيم المهن والخدمات الصحية، وتنوب عنها الدكتورة أزهار نصيب. ويأتي تنظيم هذا المؤتمر تأكيداً لما توليه القيادة الرشيدة من اهتمام كبير بصحة المواطنين والمقيمين، وحرصها على تقديم الدعم والرعاية السخية لجميع الفعاليات العلمية والأنشطة والمؤتمرات، سعياً نحو الارتقاء بمستوى الخدمات الصحية المقدمة في مملكة البحرين. الأخوات والإخوة، حضورنا الكريم، إن خير ما نبدأ به حفلنا آية من الذكر الحكيم.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الرحمن علم القرآن، خلق الإنسان، علمه البيان. الشمس والقمر بحسبان، والنجم والشجر يسجدان. والسماء رفعها ووضع الميزان، ألا تطغوا في الميزان، وأقيموا الوزن بالقسط ولا تخسروا الميزان. والأرض وضعها للأنام، فيها فاكهة.
صدق الله العظيم. أما الآن فمع كلمة افتتاح المؤتمر تلقيها الدكتورة أزهار نصيب، رئيسة قسم الأبحاث السريرية والتعليم الطبي والتطوير المهني المستمر، فلتتفضل سعادتها مشكورة.
بسم الله الرحمن الرحيم. شكرا لتواجدكم معنا في هذا المؤتمر في نسخته الثانية. أنقل لكم تحيات سعادة الدكتورة مريم الجلاهمة، الرئيس التنفيذي للهيئة الوطنية، وطبعا تعتذر لأنها عندها صادها ظرف طارئ، فاسمحوا لنا عن عدم تواجدها، وإن شاء الله I am deputizing here in this opening ceremony. بسم الله الرحمن الرحيم. السيد رهيج، المدير التنفيذي للمستشفى الملكي للنساء والأطفال، الدكتور حاتم شوقي، رئيس المؤتمر، الأطباء، أعضاء اللجان العلمية والتنظيمية للمؤتمر، السيدات والسادة المتحدثين من داخل مملكة البحرين وخارجها، الحضور الكريم، السلام عليكم ورحمة الله وبركاته. يسرني في البداية أن أرحب بكم في افتتاح النسخة الثانية لمؤتمر صحة الأم والطفل، والذي ينعقد في ظروف استثنائية عالمية بسبب وباء جائحة كورونا التي ألمت بالعالم. ويسعدني التحدث أمام هذا الجمع الكريم من الأطباء والباحثين والخبراء الأجلاء والمجتمعون للتباحث والتداول في أحدث المستجدات فيما يتعلق بصحة الأم والطفل، وخصوصا النساء في سن الإنجاب، وما يتعرضن له خلال فترة الحمل والولادة، خصوصا في هذه الفترة من الظرف الصحي الاستثنائي، والذي سلط الضوء بشكل كبير على أهمية الرعاية الصحية ودور الكوادر الطبية والعلماء والباحثين في التصدي للجائحة العالمية. لقد أصبح واضحاً تأثير وخطورة هذا النوع من الأمراض على صحة الفرد والمجتمع، ودورها في تعريض حياة الأشخاص للخطر خصوصاً خلال فترة الحمل، مما يحتم على الكوادر الطبية والتمريضية جميعاً الاهتمام والتركيز لإيجاد حلول علمية وطبية سريعة لمساعدة النساء في إكمال فترة الحمل بسلامة وإتمام الولادة بأمان، وتقديم الرعاية الكاملة إلى الأم والطفل، والتي تعتبر خلال هذه المرحلة تحدياً كبيراً للعاملين في القطاع الصحي، وكذلك للمهتمين في إعداد الأهداف والخطط التنموية. تسعى مملكة البحرين دائماً لتكون سباقة في توفير الرعاية الصحية والخدمات الطبية المتطورة والحديثة، ويظهر هذا جلياً في القرارات الحكيمة التي يأمر بها سيدي صاحب الجلالة الملك حمد بن عيسى آل خليفة ملك البلاد المفدى حفظه الله ورعاه، وبالمتابعة الحثيثة لتنفيذ هذه القرارات من قبل سيدي صاحب السمو الملكي الأمير سلمان بن حمد آل خليفة ولي العهد رئيس مجلس الوزراء المؤقر حفظه الله ورعاه، لتكون صحة الفرد والمجتمع على رأس أولويات قيادتنا الحكيمة وحكومتنا الرشيدة. وما تحقق من إنجازات في تصدي لوباء جائحة كورونا خير مثال يحتذي به، حيث تم العمل وفق خارطة الطريق التي عدتها مملكة البحرين الغالية، وحرص الفريق الطبي على تنفيذ توجيهات وتوصيات صاحب السمو الملكي الأمير سلمان بن حمد آل خليفة ولي العهد رئيس مجلس الوزراء المؤقر رئيس اللجنة التنسيقية لمكافحة فيروس كورونا وحفظه الله ورعاه. إن جهود الفريق الوطني حققت نجاحاً كبيراً في مواجهة الأزمة بإشراك عدد كبير من الوزارات والهيئات ومساندة المجتمع المدني، حيث أظهر الجميع التزاماً كبيراً بالمسؤولية، والذي يمثل المكمل الأساسي للجهود والقرارات والتوصيات، وركيزة هامة لنجاح كافة الخطط للمساهمة في القضاء على الفيروس وحفظ سلامة وصحة الجميع. إن عقد هكذا مؤتمرات في ظل هذه الظروف يعتبر تحدياً كبيراً ومتميزاً يساهم في بناء القدرات البشرية ومناقشة المستجدات العلمية والتعرف على طرق تقديم الرعاية الصحية أثناء الأزمات وكيفية مواجهتها، وخلق مناخ صحي وإعلامي لبث الطمأنينة وتأمين الحياة الكريمة للجميع من خلال استخدام الخبرات المحلية والعالمية لمناقشة مواجهة التحديات الصحية وابتكار استراتيجيات جديدة لطرق الرعاية الصحية في علاج ومكافحة الأمراض. وختاماً، لا يسعني إلا أن أتقدم بالشكر الجزيل والتقدير إلى القائمين على تنظيم هذا المؤتمر العلمي الهام، وأخص بالشكر لجان المؤتمر العلمية والتنظيمية والجهات المشاركة والداعمة لتنظيم هذا المؤتمر، وإلى جميع الحاضرين والمشاركين، وأعرب لكم عن تمنياتي بأن يحقق هذا المؤتمر الهام الأهداف المرجوة التي سوف يعقد من أجلها، وأتمنى لكم كل التوفيق في أعمال مؤتمركم هذا والنجاح الدائم لخدمة مملكتنا العزيزة الغالية وأهلها الكرام. والسلام عليكم ورحمة الله وبركاته.
نشكر الدكتورة أزهار نصيب على كلمتها. والآن يتفضل السيد روهيت المدير التنفيذي للمستشفى الملكي للنساء والأطفال بإلقاء كلمته مشكورا، فليتفضل.
Good morning, everyone, doctors, health professionals, and all the guests. It is with great pleasure that I welcome you all to this second edition of Maternal and Child Health Congress, or I think I should say second season, as we are all used to these days. So second season of Maternal and Child Health Congress, or the MAC Congress, as we say it. Thank you, Dr. Azhar, for representing Dr. Mariam Jalama. We will miss her presence in the event, but at the same time, I would like to thank her for her continued patronage and support for the MAT Congress. A special appreciation to our leaders, Dr. Hatim Shauki, the chairman of the Congress, Dr. Sohail Shabib, vice chairman of the Congress, and the organizers, Dr. Salman, Dr. Amin from the Education Plus, and their team. On behalf of Royal Hospital for Women and Children, we extend our gratitude to all the speakers and presenters, especially those who are presenting from overseas in different time zones. And I would also like to extend a word of thanks to our sponsors for supporting the event. At Royal Hospital for Women and Children, we are committed in providing the best of healthcare to all women and children. With addition of specialties like IVF, cosmetics, laparoscopic surgeries, orthopedics, gastroenterology, and many others, we ensure that we take care of the woman from the time they take birth to the time they give birth. Addition of super specialties in pediatrics has also provided the value addition that we intend to bring to the society at large. Maternal and child health is an important healthcare feature of any society. And when a healthy mother gives birth to a healthy child, future leaders are born. And this is from where we derived our theme for the Congress, a hopeful start for a fruitful future. During this journey of 2 days, we will learn from various sessions that broadly cover a wide range of topics related to maternal and child health. We have an eminent panel of speakers in various fields of medical expertise in our program, and we are confident that these shared experiences will help us reach the goal of the Congress and benefit all contributors. Again, I thank you all for your presence, and I hope that you all have a pleasant time and will find this a productive occasion, both personally and professionally. Thank you.
نشكر السيد روهيت المدير التنفيذي للمستشفى الملكي للنساء والأطفال على كلمته. أما الآن فلنشاهد معا عرضا توضيحيا قصيرا عن أهم الخدمات الصحية المقدمة في المستشفى الملكي للنساء والأطفال. أما الآن فمع كلمة الدكتور حاتم شوقي رئيس المؤتمر فليتفضل مشكورا.
Good morning. On the behalf of myself and the conference committee. I would like to thank Dr. Azhar Nasib for her attendance on the behalf of Dr. Mariam Jalahmed, the CEO of the NEHRA, who gave us the chance to organize this Congress under her patronage. As we started last year, MEC conference is considered to be the first conference in Bahrain, gathering most of the updates of the obs and gynae and infertility together with pediatrics at the same time, with most of the subspecialties of both under the umbrella of the Royal Hospital of Maternity and of Mother and Children. Our eminent speakers, dear colleagues and respectable audience, we are here to continue what we have already started last year, to be always on an integral path with all the medical updates. And lastly, the Royal Hospital for Women and Children, together with the conference committee, always have fruitful ideas to escalate the rank of this conference to be on the international agenda in the coming few years. I hope you will participate actively in the sessions, and I hope that you have a nice time for today and tomorrow. Thank you very much.
نشكر الدكتور حاتم شوقي على كلمته. الحفل الكريم. أما الآن فليتفضل السيد روهيت والدكتور أمين والدكتور محمد سلمان لتسليم في النهاية لتكريم راعي الحفل الدكتورة مريم الجلاهمة، وتتسلمها بالإنابة الدكتورة أزهار نصيب. فليتفضلون على المسرح مشكورين. أما الآن فليتفضل الجميع لالتقاط الصورة الجماعية مع الدكتورة أزهار نصيب. فليتفضل الجميع على المسرح. ما عليك يا ممر، في أحد من رؤساء الأقسام من الهيئة يتفضلون على المسرح لأخذ الصورة؟ لا بس بعد أول صورة بروحهم بس. فليتفضل الجميع لالتقاط الصورة الجماعية على المسرح. الصفوف الأولى لالتقاط الصورة الجماعية. ما عليك مامر، بس ناس تحت عشان الصورة تبين واضحة.
أنا شخصيا هنزل تحت.
فليتفضل الجميع لالتقاط الصورة الجماعية. نشكر الجميع. شكر خاص للرعاة، الراعي البلاتيني شركة صيدليات حمد تاون، الراعي الفضي شركة ميرك، الراعي الفضي شركة نتيشة لدعمهم للمؤتمر وإنجاحه. من بعدها جولة في المعرض المصاحب، ومن ثم بدء الجلسات المؤتمر العلمية. فليتفضل الجميع للجولة في المعرض المصاحب. شكرا لكم جميعا.
محمود، هنقعد فين يا احمد؟ مش هنقعد في النص كده.
Move this one. روح كليكر بوت كليكر.
Starting the scientific session now. Please, can you sit? We will starting the first session. And we apologize for this delay, but we will try to be back on track for all the session. How many online now? One. Also, we have more than 100 attendees online with us. So we have we are doing an unlimited seat for the physical. You know, still the corona is still there, so we are not invited large number for people to attend the physical, and we are open the registration for virtual. So for the OBS and Gynae, now we have more than 100 attendees, and we will starting now the first session.
Assalamu alaikum. Good morning, everyone. It is my pleasure, and I would like to thank this is the organizing committee of the MACTO for inviting me for these sessions. These sessions will be started with presentations of Dr. Hatem Shawi. Dr. Hatem Shawi is the chairman of MACTO Congress, and he's a consultant of obstetric and gynecology and infertility at Royal Hospitals for Women and Children. He's more than 35 years of experience in this field. Actually, he's my senior one at the University in Al-Azhar University in Egypt. Okay, you are welcome.
Good morning. We are really sorry. I'm speaking as the chairman of the Congress that for this delay, and we'll hope we'll catch up. I will minimize my talk to 20 minutes, and I will postpone any questions for the end of the session, or even if we don't have time at the end of the session, we are happy to, especially for those who are online, to write for us their questions. The topic of today is really challenging. And actually, I am, with this topic, I'm trying to raise a problem, not to solve a problem. Controversy of timing of embryo transfer for PGT. The decision of taking the biopsy from an embryo, either day 3 or day 5, this decision is taken on so many parameters and so many criteria. But these criteria are at the end under the influence of the meta-analysis. We can't have a concrete evidence that this is better than that. So at the end of the day, you will have a group of infertilologists like to do or believe in making this biopsy on day 3, and others believe that it is better to be day 5. I know that some of those who are attending, maybe this is the first time they hear about these details of our subspecialty, but I will try to simplify it as much as I can, so that at the end of the day, we have a message to all who are hearing me. I'll start first by history. The PGT, which is the pre-genetic testing, is an early form of pre-genetic diagnosis where abnormal embryos are identified, thereby allowing the transfer of genetically normal embryos. This is what we believe, that when we take a biopsy, we are checking this embryo. If it is normal, we will transfer it, and if it is not, we will not transfer it. But actually, this is not the whole truth. The development of PGT technology started 1 century before, in 189. And after 100 years, there was a report for the development of this pre-genetic diagnosis for the sex-linked diseases, only for the sex-linked disease. And then before the end of the century, there was an introduction to the technology which we call it, which we call it the immunoarray, which we can identify the embryos at the blastocyst, which is day 5 of the age of the embryo. All this is a history, but where we stand now. We have new terminology now. If we are looking for screening the embryos for if it is euploidy or aneuploidy, we call it PGT-A. If we are looking for the structural arrangement of the chromosomes, we call it PGT-SR. And if we are looking for any monogenic disorder, we call it PGT-M. This is the most recent terminology, so that if I use it in the coming slides, it will be. We have techniques for this biopsy all through the history. We have the polar body, which is done at day 0 or day 1. We have day 3, which is 8-cell or the blastomere, and we have day 5. These are the 3 days where it is possible or where it has been tried to take the embryo biopsy. In day 3, there are so many techniques for this embryo transfer. We have the aspiration technique, we have the extrusion technique, we have the displacement technique. The idea is to have one cell from this 8-cell and to examine it, and from the result we have from this cell, we judge on the remaining cells. This is the idea. Okay? And accordingly, we will make our statistics, and accordingly, we will take our decision. In day 5, from the age of the embryo, we have a blastocyst. The blastocyst, if you remember from your embryology, we have a cell mass and we have cells around the blastocyst. We call it the trophoectoderm. And we have fluid inside. So if we take a cell or few cells from the cells around the surface, we can do the same thing. We can examine them and have the result, and according to the result, we will judge on the whole blastocyst. So the question is, which is better? To do it day 3, to take one cell from the 8 cells, or to take one cell from the trophoectoderm, from the blastocyst, from the trophoectoderm, and have the result. We'll see. In this study, the reasons of, we'll start first, why we discarded the polar body, because it tests only maternal errors and it cannot test for post-zygotic errors. So forget about the polar body as a timing of taking the examination for or testing the embryo. We will concentrate on day 3 and day 5. This is what was 2017. In this paper, which is in 2000, you see better than me. The use of the ectoderm biopsy for interrogating embryos at risk for sickle cell anemia appeared to be superior to the blastomere aspiration. So this group said that day 5 is better than day 3. And then another paper done in 2018 also to assess the benefits and harms of day 5 embryo biopsy in comparison to day 3. They found the following. Both are harmful, as any process of biopsy may affect the development of the embryos, which is logic. There is the possibility that biopsy may negatively impact on pregnancy rates and prenatal outcomes. The diagnostic error rates are higher in day 3, resulting in normal embryos are not transferred. If we are trying to summarize the pros and cons of this, we'll find the following. Not every embryo would reach the blastocyst stage of development, waiting for day 5 biopsy, may result in no PGT-M test or no transfer. Following day 5 biopsy, embryos typically need to be cryopreserved and then thawed. Thawed means warmed or defrozen, which precludes that the transfer of a fresh embryo. Furthermore, not all embryos can survive the freezing and thawing process. What is with the removal of multiple cells by day 5 rather than a single cell by day 3 could potentially lead to improve sensitivity of the genetic diagnosis, which is also logic. What's with and what's against is also logic. We'll see another paper in 2000. Kamyanov, read. مش شايف. Overall implantation rates are higher for embryos biopsied and vitrified on day 5. So they are again back to day 5 is better. When the data were stratified by age, there was a clear trend of higher implantation for all age group except above 40 for day 5 embryos. However, statistical significance was reached only in 35 to 37 years old and 38 to 40 years old group. Day of embryo biopsy should be considered when selecting embryo for frozen embryo transfer. Further study should be determined. So far, we don't have a concrete decision which is which, but so far they are with day 5. This paper, they say, our data suggests that delaying biopsy to potentially improve embryo quality does not result in a significant increased pregnancy rate. So back again to square one. If we make it day 5, it will not improve. In this paper, day 3 biopsy and day 4 fresh embryo transfer strategy is a viable option, especially in patients having concerns about blastocyst culture and frozen embryo transfer with the ovarian hyperstimulation risk. Back again to day 3. The result of the current study suggests that biopsies should be performed on fresh embryos rather than on frozen embryos. So, in between brackets, we will not follow day 5 because they will be frozen. In this study, the effect of the PGT-A bipolar body biopsy on improving clinical pregnancy rate is uncertain. We said this before. The blastocyst stage biopsy, it is uncertain whether the PGT-A with blastocyst stage biopsy reduces miscarriage rate. No data on ongoing pregnancy rate or clinical pregnancy rate were available. And they are all recent. 2020, 2019, 2018. Further studies evaluating the cumulative live birth rate per started cycles in day 3, day 4 embryo biopsy for PGT-M are warranted. Biopsy on day 5 is more likely to have better morphology and better transfer outcomes. Further studies are needed to determine whether larger sample sizes would show similar findings. The utilization of PGT suggested the beneficial effect of a woman of advanced age. In view of the limited reports, further studies are warranted to confirm the effect of different stages of embryo biopsy on pregnancy outcome. So we are still in the middle of nowhere. Biopsy on day 5 and day 3 are not adversely affect embryo viability, spindle chromosomes configurations, and ultrastructure, although following vitrification, minimal embryo quality and cell damage are observed. And here is the list of the advantage and disadvantage of day 3 and day 5. I will not read it all to minimize the time, but there is a list of advantage and disadvantage of both. How embryo biopsy may affect development. With regard to blastomere biopsy, no research has been carried out to investigate whether or how the removal of one cell from a developing embryo could trigger adaptations that persist further in development. Here is the problem. With regard, the second paragraph, with regard the trophic ectoderm biopsy, there is no extensive knowledge concerning determined effects on both pre and post-natal life. So what's the result at the end? The conclusion is confusion. What to do? Day 3 or day 5? Freeze or don't freeze? Fresh or not fresh? Each one will come up with a result or with a study saying this and with this or against this. But at the end, there must be at least a solution, or at least thinking outside the box. And the reason why the solutions, we think about the solutions, is that we know that there is a problem. If we are satisfied with what we have, then we'll not think that how to improve what we have. But because we know that there is a problem, so we are thinking there must be a solution. The solution, I think, will not be this year or next year, or it will be in few years. This future is the non-invasive pre-genetic test diagnosis. This non-invasive means I will not touch the embryos. I will take from the DNA swimming in the media. By that, I will not interfere with the embryo. I will take more than one DNA from most of the cells, and I will be near to the truth and overcoming the problems of the biopsy. But still, this is under study. But I think the approach of the whole world will be to discard the traditional, conventional PGT, which we are doing now, and we will come up to the non-invasive. There is another way for this non-invasive, but it is invasive, which is the blastocentesis. The blastocentesis is to take a sample from the fluid inside the blastocyst, having the same idea that I am taking the DNA of more than one cell and testing it. Until this happens, visit Egypt and have rest. Thank you.
Thank you very much for your excellent presentations. And as you said, it is a field of controversies that you are adding more and more questions. And I think in the next years, it will be more and more questions. There is no solution for this. Maybe that is to ask us why they changed from BGD to BGT. Yeah.
Ask Dr. Mali.
Thank you. There was a meeting of PGD, International Society, about 4 years ago in Brussels, and they changed the term from PGD diagnosis to PGT testing. So today we don't use the term PGD. It is PGT is more inclusive, and it includes all the tests which Dr. Hatem explained. And in that particular meeting also, this issue was discussed very intensively. And it was decided to go for most of the scientists to go for day 5 biopsy, freeze the embryos, and give the time for PGT laboratories to do their job within few days until the result is ready. Then you can return the embryos later, 2 months later, 3 months later, after the gynecologist stimulates the endometrium and sees that it is the right time for returning the embryos. It will give more flexible time for the laboratory instead of doing the biopsy on day 3, waiting for 2 days to get the results. Really, PGT is labor intensive, no matter what. All types of PGT are labor intensive and it takes time. So I myself, I prefer to do the biopsy on day 5, whether it is you are taking trophic ectoderm or you're taking the culture medium for free DNA, then freeze these embryos and you can return them later after the result is ready. All right?
Thank you very much. Next. So we are moving for the next speaker.
the next speaker, we have Dr. Noof Behzat, consultant of Obsangaini, and she will give us a presentation of the nightmare of obstetricians, oasis in modern obstetrics. The floor is yours.
Bismillah ar-Rahman ar-Rahim. Good morning, everyone. Before starting my lecture, I would like to thank the organizing committee for giving me this opportunity to speak today in today's Congress. Well, when I was a junior resident, it was really a nightmare to me. At any time of the day, if I would be called or I'll receive a call from the labor ward and the midwife is telling me that there is third or fourth degree perineal tear. Come and see the patient. Actually, I worked hard to master recognizing and treating these cases, and I think I have good training. When I became a consultant, I had another nightmare, which is to be called in the middle of the night for any reason and to drive after 12 a.m. to reach Salmania Medical Complex. That was my nightmare. Let me start my lecture with the classical way in reviewing the anatomy. I cannot see it. I cannot see the screen. My screen is not changing. What if I have the screen?
No.
So, fecal and gaseous incontinence are controlled by what is called the anorectal complex. And you can see this picture clearly, isn't it? So the anal canal is a structure which is 2.5 to 4 centimeters in length, and the muscular bulk is formed by the internal and external anal sphincters. It is lined superiorly by the fusion of the puborectalis muscle, forming the anorectal junction or the anorectal ring, and inferiorly by the intersphincteric groove. The inside of the anal canal is divided by what is called the pectineal line or the dentate line, in which the anal valves are present, and it divides the anal canal into a proximal part and distal part. Regarding the internal anal sphincters, is formed by circular smooth muscles innervated by the autonomic nervous system, and it controls like 85% of the resting anal tone. Any injury to the internal anal sphincter causes soiling of stool and fecal incontinence. The external anal sphincter is formed by stratified striated muscles, and it controls the squeeze of the anus to differ defecation. It is controlled, or it is innervated by the pudendal nerve. Any injury to the external anal sphincter causes fecal incontinence. So by definition, obstetric anal sphincter injury is something which happens after delivery immediately or during the normal vaginal delivery, and it encompasses both third and fourth degree perineal tear. And according to Sultan classification, the third degree involves the external anal sphincter or internal anal sphincter. And when the anal or rectal mucosa are involved, this is considered as fourth degree perineal laceration. A meta-analysis of 8 studies were reviewed. More than 99,000 women were studied, and they found that the overall risk of obstetric anal sphincter injury is like 6.3%, and it is more in primigravidas. The risk also, twin pregnancies also, twin who delivers both twins vaginally, they carry a risk of 2.8% having a sphincteric injury. It's very important for us as obstetricians, when we deliver a patient in the labor ward, or even when we follow a patient in the antenatal period, to highlight the risk factor which this patient might be having. Unfortunately, vaginal delivery itself is a risk factor. So any patient who undergoes vaginal delivery, we have to make sure that she doesn't have any we have to examine the patient immediately after delivery and make sure that she doesn't have any type of sphincteric injury. Prolonged second stage of labor, more than 3 hours, is one of the risk factors. And it was found that obstetric anal sphincter injuries increase in primigravidas with Asian ethnicities and those who used epidural anesthesia or analgesia. Episiotomy is used commonly in labor ward, but actually it should not be used as a routine unless it is indicated, unless it is obstetrically indicated. And if it should be used with an indication, we prefer to use a mediolateral episiotomy because the risk of sphincteric injury will be less than using a medial episiotomy. Actually, I attended an international conference before the COVID era, and I was discussing with one of the professors regarding operative vaginal delivery. And surprisingly, he told me that, or his opinion was that there is no place for operative vaginal delivery in modern obstetrics. But in my opinion, as long as we are still having vaginal deliveries, there is a place for operative vaginal delivery, but with indication and limitations. Operative vaginal deliveries carries risks for both mother and fetus, of course, so it should not be done unless it is indicated. With the forceps delivery carrying a higher risk of having obstetric anal sphincter injuries. A study found that all patients who have 80% of patients who underwent forceps delivery, they develop what is called delayed obstetric anal sphincter injury when they present with fecal or flatus incontinence later on, years after the postpartum period. Birth weight also, or fetal macrosomia, is attributed to, is one of the causes to have an obstetric anal sphincter injury. And of course, shoulder dystocia with 9% increased risk and prior obstetric anal sphincter injury. Okay, regarding the clinical presentation, actually, I went through the literature and there is no international agreement about the subtypes or classification of obstetric anal sphincter injuries in terms of clinical presentation. Okay, but what I found it interesting and up to date that they have classified it or divided it into 3 subtypes according to the time frame when the patient present with symptoms into immediate, postpartum, and delayed. So the immediate is where there is an obvious laceration diagnosed immediately after delivery. When you deliver the baby, and the placenta, examine the patient and you find that she has an obstetric anal sphincter injury. This is called an immediate oasis. If the patient presents to you 6 to 8 weeks postpartum with perineal pain or discomfort, bleeding or abnormal discharge, or even loss of bowel control, then you have to consider that this patient might be having a missed, an undiagnosed obstetric anal sphincter injury, or an injury which was diagnosed but not repaired and required to be repaired in the postpartum period, or even an injury which was recognized, diagnosed, and repaired at that time, but later on she's coming now in the postpartum period with these symptoms as a complication. Delayed obstetric anal sphincter injury is when the patient comes to you with loss of bowel control, fecal urgency, years and years after delivery. So she might have her last delivery 20 years back and she's coming to you now with these symptoms. Regarding the evaluation and the management, as I said earlier, any lady who delivers vaginally, she is at risk of having an obstetric anal sphincter injury. So we have to examine the patient properly, have a good exposure, good analgesia, make the patient comfortable so that you will have a good exposure to the tissue and you will be able to diagnose or to ascertain the extent of the injury. You have to have, So diagnosis, once you diagnose it, once you diagnose the immediate obstetric anal sphincter injury, immediate surgical repair is the mainstay for treatment, whether you will choose the end-to-end technique or the overlapping technique. And I'm not going to go through the techniques and the types of the suture in this lecture because it will take a bit long. So the repair can be delayed sometimes. Sometimes you don't have, I'm an obstetrician, I might not have an experience to repair such injuries, or I don't have anesthetist at that time, OT is not available, so resources are not available at that time. So I can delay the repair for up to 12 hours without any apparent detrimental effect. So it's better to do a proper delay, a proper repair, even if it is delayed, and not to hurry and do it and you are not confident enough. After you do the repair, you have to follow the protocol, which is followed in your unit. Cover the patient with a broad-spectrum antibiotic to avoid wound dehiscence and infection, and you have to give the patient laxatives. Bulking agents are not recommended to be given along with the laxatives routinely. Recommend doing pelvic floor physiotherapy after proper healing because this will be beneficial for the patient. And for women who are undergoing repair of obstetric anal sphincters injuries, they should be reviewed and monitored closely by an obstetrician who is interested and experienced in dealing with these cases. For women who are, while you are following your patient might have a transient complaint of uncontrolled bowel. So these patients has to be referred to a urogynecologist who has experience in anal sphincter repair or to an anorectal surgeon. What happened? Okay, if the patient came in the postpartum period, 6 to 8 weeks postpartum with fecal urgency, fecal or anal incontinence, pain in the perineum, or discomfort or abnormal discharge, then you have to examine your patient again properly, look or find out if she's having any sort of lacerations, check for an evidence of normal healing, do vaginal examination, do rectovaginal examination and feel the septum, rectovaginal septum, and do an anorectal examination and ask the patient to squeeze while you are doing the examination to feel if there is asymmetry or defect, which is most probably will occur in the anterior part of the rectum. You have to consider that this patient, as I said earlier, might have an injury which was missed or an injury which was repaired and now she's coming with complications. Sometimes you might need to remove sutures just to check the extent or the depth of the separation of the tissue. And if there is any hematoma, hematoma has to be evacuated. If there is any abscess, it has to be drained. Do not rush into an immediate repair if the patient is having signs of infection. You have to treat the infection first. You have to debride all the necrotic tissue and have a clean, fresh vascular margin, and then go ahead and do the repair, just the same as the primary repair. For occult or delayed obstetric anal sphincter injury, the patient will come with anal incontinence, which is fecal and stool incontinence. She will come years and years after delivery. And actually, one of the studies found that up to 35% of patients with obstetric anal sphincter injuries, when they have done an ultrasound at 6 and 12 months, they found that there is a defect. So these patients might have a defect even if the sphincter was repaired. Okay, it might not be a successful repair. So you have to consider, even if the patient underwent a repair, she might have these symptoms still, she might have a defect. What is characteristic when you examine this patient, you will see what is called the Dobby-Tail sign, as it is shown in this picture. Once you see it, examine the patient again, do an endoanal examination, and perform an endoanal ultrasound if it is available. Some will do an MRI if they don't have the facility of an endoanal ultrasound, and especially if they are thinking that this patient might have a fistula. These pictures are showing the one in the middle is showing the internal and external anal sphincters, which are intact, and this is a normal image of endoanal ultrasound in comparison to the second picture, which is showing an intact internal anal sphincter and a defect, which is showing the upper part of the external anal sphincter. The goal of the treatment is to both restore the anatomy and the function as well. So, reconstruction of cylindrical anal canal utilizing both the external anal sphincter and the perineal body scar to allow a circumferential contraction of the anal musculature when the patient attempts to stop or defer defecation. Of course, you have to know about the prognosis, especially when you counsel your patient. After a primary repair, there is a 3 to 5% risk of having a repeat oasis, with 47% risk of having anal and fecal incontinence later on in life. And if the internal anal sphincter was affected, so the patient might have more complications. She might come up with immediate complication and even delayed symptoms more than if she had only an external anal sphincter injury. Women with a prior to obstetric anal sphincter injuries, they have a higher 10 times or 10-fold increased risk of sphincter injury and the risk in the next pregnancy, with an increased risk of having fecal incontinence. Fecal incontinence, anal incontinence, defecatory and urinary dysfunction, dyspareunia, and chronic perineal pain are all long-term complications which has to be considered when you see a patient in the clinic. Okay, what about a future approach? Your patient will ask you this question: what about my next delivery? And even for you as a consultant, when you decide when you see your patient in the antenatal period, you have to decide regarding the future pregnancy. So patient with a single obstetric anal sphincter injury, an asymptomatic patient, can be counseled regarding the mode of delivery, and she can be given a chance of having a vaginal delivery, provided that you explain all the risks on the short and the long term and the risk of repeated oasis to the patient, and you have to document this. At the end, it's a patient decision. You have to make it clear to the patient that the rule of episiotomy or prophylactic episiotomy in subsequent to pregnancy is not actually is not clear. If episiotomy will be performed, there is risk, although it is lower than if episiotomy was not performed. And we don't, as I said earlier, episiotomy should not be used routinely unless it is indicated. For patients who are symptomatic after primary oasis, or who have prior to injuries, or who have a defect shown in the endoanal ultrasound or even in manometry, they should be counseled regarding the option of going into an elective cesarean section, provided that you explain to the patient the risks and benefits, the pros and cons of each route. Okay. Can obstetric anal sphincter be prevented? Know your risk factors. Counsel your patient. If episiotomy is indicated, then give a right mediolateral episiotomy in a state of a median episiotomy with a 60 degrees angle, not less than that. The closer to the anal sphincter, the more risk of having injuries. Perineal protection, actually NICE guidelines initially, they said hands-on or hands-off the perineum during delivery of the head will not make any difference, but 2015 Green Top guidelines said that perineal protection during crowning is a protective. Warm compressions might help in reduction of anal sphincter injury risks in patients and primigravidas. Okay, risk management is very important. For each unit, they have to have a plan for risk management. Each unit, they have to have their own statistics. They have to put a protocol, how to diagnose these patients, how to manage them, and how to follow them after that on short and long term. The patient, everything has to be clearly documented. The type of injury has to be documented, and the patient, this should be addressed clearly to the patient. And also, so risk management is very important. Review annually is very important. Statistics has to be done annually so that we will improve the quality of services in our units. And at the end, I just wanted to say something. These are symptoms which might not come into your mind when you see a patient who is 40 years old or 30 or 50 years old coming with anal symptoms. You might not think that it might be because of a delivery 20 years back, but consider obstetric anal sphincters injuries, that this might be missed. It might be underdiagnosed. Listen to the patient, investigate the patient, and give her a good quality of life. Because I always say, a happy mother is a happy family. Thank you. I'm sorry if I took longer time. Yes, of course. If anybody have any
no, just
comment?
I have just two comments. That is nightmares. It is not for obstetrician only. It is for the medicine. Alas, but we are on the top of it. Okay. Alas, from the etiquette point, I will not ask you how old are you.
I'm 45.
No, I will not. And I will not tell you how old am I. Okay, but until yesterday midnight, I was running in the street because to saving a perimortem. cesarean section. It's okay. It is our destiny. But in Germany, 30 years ago, they divided the department to gyne and obstetrician, and the obstetrician should not be more than 45. Okay, it is over. Regarding another point, when your professor told you that is no way or no rule for operative vaginal delivery, I do accept from 2 points. First point, we lost the art of operative vaginal delivery. So regarding the forceps or regarding that. I had a study 15 years ago, okay, and we discovered that it's all the primaries who had forceps deliveries. 50% of them had hidden perineal tear and the anal sphincter tear. And it is a shame always, it is this point from our culture that is the lady to come and to say, I am not controlling the cases on this point. So, and the second point for us, we are in a very high critical medical legal area, okay? Don't use any instrument until you are sure how to use it and the patient will be happy with it. So otherwise, don't put you in the field of medical legal for anyone who doesn't understand anything and coming to blame you. That is my point. I'm sorry.
No, you are totally correct, and I'm totally with you. Instruments should not be used unless it is indicated and by a trained person.
We lost the art, yeah, doctor. This is a lost art. Vacuum, forceps, and added to it, that is, we are in a very high critical medical legal litigation. Everyone is going to complain. It is my opinion. I'm sorry if anyone of the audience, of the colleagues.
Thank you for this hot discussion, and we'll, sorry to catch up our schedule, and we are waiting for Dr. Fatma Khan for her presentation. And Dr. Fatma Khan is consultant of Obs and Gynae Oncology, and currently she is in Salmania Medical Complex Department, and we are waiting for your presentation. Thank you, Dr. Fatma.
Thank you, Dr. Houghton, for introducing me. I would give her the 5 minutes. I'll finish before the 30 minutes now. So detection and pre-cancer, it is very important in a way to prevent the cancers. So many guidelines are being there. So, but I prefer the American Society Colposcopy and Cervical Pathology, their guidelines, because it's easy to use and it's easy to understand and reach for the management for the patients, and even in the term of testing, what is the timing to test and when to do the treatment for the patients. It is 2019. I know it is late. We are now 2022, but this guideline, I don't think that everybody knows about it. The new guideline is different than the other guidelines, and we'll come through it. So we'll go through the content of 2019 guideline and how this guideline differs from the other guidelines, the latest, the previous 2012. And we'll discuss most cases, scenarios that when the patient attend to our clinic, especially when they are attending first to family physician. I will not go through all these sections. It is because it will take more than a whole day to explain all the section contents of these sections. It consists of sections, and it is divided from A to K. Then it is later subdivided. So this is the 4th American Society of Colposcopy and Cervical Pathology Consensus Guidelines. And the management's recommendation accommodate the available 3 screening strategies that we have. We have the primary human papillomavirus testing, which were introduced in 2015, co-testing with HPV and cervical cytology. The aim of the 2019 guidelines is no harm and is balance between in a treatment, no over testing or over treatment. So that we have two types of patients, patient with low risk and patient with high risk. Patient with low risk, like HPV positive with negative intraepithelial or no malignancy cytology, ASCAS and lower grade SILL, they do not need treatment, or they do not need even frequent testing if we compare it to the high grade patients. 2012 guidelines, it was the first guideline was based on the principle of equal management for equal risk, specifically the risk of patient developing cervical cancer estimated by the surrogate endpoint of the year of 5-year risk of cervical intraepithelial neoplasia, CIN3, or more severe diagnosis, regardless of which test combination yielded this level. But unfortunately, it was a complicated guideline. Complicated, it has algorithm and insufficiently incorporated screening history. 2019, the management recommendation, it's based on the patient's risk of developing cervical cancer or pre-cancer. So it depends on the current screening test results, previous screening tests, and biopsy results. They found, because the three, it is very important to create a risk, to be a risk for a pre-cancer if we detect them and prevent them. So the data needed for 2019 guideline, we need to generate recommendations, depends on the patient's age, current result, and past history. If the patient, she has a known history of previous tests of cytology or HPV, whether she treated or not, and if her past history unknown also. So 2012, it is a risk-based guidelines, the algorithm, all they based on results, it's based on the results. Whereas 2019, it is a risk-based guideline. So the essential changes in 2019 guidelines, recommendations are based on risk, not results. Meaning, if we have like two patients, they have in the same age, they have same results, but the history is different, or a previous test is different, the recommendation for treatment with the current cytology or pathology, it will be different, because it estimated the risk differently between the two patients. And the recommendation for colposcopy, treatment, or surveillance will be based on risk of CIN3 or more. When we say CIN3 and plus, we mean CIN3 itself, adenocarcinoma in situ, and rare cervical cancers that may be detected during the examinations. Expedited treatment, previously in 2012, it was an option for high-grade SILL cytology. Now it is better defined. We mean expedited treatment as a treatment without preceding colposcopic biopsy. We can do excisional without doing the biopsy colposcopy. And these two will explain it later with more slides so we can understand what does it mean, the estimation of risk of CIN3. Surveillance, this guideline, it depends on HPV tests. Because as we understood and we know now, we are sure that HPV is the main reason for cervical cancer, and the precancerous changes for the cytology to the high risk. So the recommendations for follow-up and surveillance, it's recommended HPV testing or HPV and co-testing. It is the preferred one. But what can we do? If I am in an institute, we do not have HPV, or the patient, she cannot afford it. So when the recommendation generates for surveillance, like to do HPV or HPV co-testing after 1 year, in this phase, we will do the cytology after 6 months. We make it more frequent. If it is recommended like after 3 years, we do it annually. Observation always is preferred for treatment for CIN1. Excisional treatment is preferred over the ablative treatment in a high grade. And if we have adenocarcinoma in situ, excision is recommended. This is very important, how to calculate risk. It is based on the CIN3 risk examined, immediate risk. And we have the 4%. It is the cut point, the 4%. If it is greater than the 4% or equal, there is a treatment, whether it starts with colposcopy on the bottom or it ended with the treatment, expedited treatment, excision. And here, there is a number, you can see 60 to 100 or 25 to 59, 4 to 24, the calculation of the risk estimated. If the patient, the immediate risk for CIN3 and more is less than 4, then she will go for surveillance. So surveillance, how long? How frequent surveillance? We have 1 year, 3 year, and 5 year, depending on the estimated risk. So it comes in your brain, and how they calculate these numbers and estimation risk, why they base it on 4. They depends on so many studies they did. The famous one is Kaiser Permanente, Northern California. It was around 1.5 million patients involved in this study. Over 10 years, they studied the HPV, the cytology. So they calculated the risk based on these studies. The next question that will come in your mind, why they use the CIN3, why they did not use the cancer, the immediate risk to be cancer, or immediate risk to be CIN2? Because CIN3 is more pathological, and CIN2, it can be regress if not treated. HPV distribution in CIN3, it approximates its distribution in the cancer also compared to the CIN2. The next question, how I can calculate and this risk, immediate risk, it will be difficult for us. So life is made easier by having technology. IT people, they are very clever and they know how to get money from us. They did for us applications for Android and Apple. These applications, it is not for free, it is we have to pay for it. And also you can enter the site. The site is for free, but I prefer to use the app. It's much easier. So here we enter the demographic data, the clinical and the past history and the clinical scenario of the patient, then the current test, then it will generate for you the estimated risk and the recommended treatment for the patient. We come now for some samples, mainly that we are facing it in the health center or even in our clinic as a gynae. But in governmental hospitals, we are using the Bethesda system. I know some hospitals, I think the BDF, their system is different than us, but most of Bahrain were using the Bethesda system as a pathologist to comment on the cytology. So it is important for us to be mentioned whether it is satisfactory or not, meaning the comment on enough cells they found to comment on it, and if the transformation zone was present or not, and then the interpretation. And if there is any comments, they will mention it. So what if patients, she present for us with unsatisfactory cytology? That means there were not enough cells to comment on it. So if she came with no HPV, unknown result, any age, we can repeat after 2 to 4 months, the cytology. If she came and she has the HPV result, it was negative, HPV test is recommended to be done after the age of 25, not less than 25. Again, 2 to 4. But if HPV is positive and we don't know the genotype, because we received that the results test for the HPV patient is positive for high risk HPV. There is no genotype. We have 15 types of HPV high risk. They have to mention what is the type of the HPV, the genotype. If they did not mention, either 2 to 4 months, we repeat the cytology, or she can go for colposcopy. It's acceptable. But if HPV is positive and it's 16 and 18, directly colposcopy. For negative intraepithelial lesion or malignant, and the transformation zone is absent. Again, from age 21 till 29, routine screening. No need to repeat the pap smear again for the patient. If she's more than 30 years, then we have 3 options. If HPV done, it was negative, routine screening. If HPV unknown, or we don't have HPV, we prefer to do the HPV test. If the HPV and cytology can repeat in 3 years, if HPV unknown, it's acceptable, but we prefer to be done. If HPV it was positive, we have to know the genotype, because according to genotype, if we know that it is 16 and 18, it means it's go for colposcopy. If we don't know the genotype, we can repeat again after 1 year. This age group considered before as a special situations, now we call it less than 25. We should not be invasive. We should not do aggressive management for less than 21 years, because most of these cases, yes, they will be HPV positive. And nowadays, Bahrain, inshallah, will be one of these countries. I'm hoping they are getting vaccinated. All the world, they have campaigns for vaccination. So young generation, they are getting vaccination for HPV. So HPV positive will be decreased, and most of them, the changes will be CIN2, and the CIN2, it will be regress compared to the CIN3 will progress. So patient of ages, she's less than 25 years with ASCAS or lower grade, we repeat the cytology after 1 year. But if somebody, we advise not to do HPV, but if done HPV, and if it's only acceptable if done only for the ASCAS, and again, if it is positive, we repeat cytology after 1 year. If negative, routine screening. But if patients ASC-H or high grade, colposcopy. How we can manage high grade cytology for infertility sparing with CIN2? CIN2 is specified observation. We observe the patient if she's less than 25 years old, and if she's more than 25, acceptable. If we are concerned not to treat and to do observation, it is acceptable if the patient concerned for her next pregnancy, but we should follow up the patients at 6 and 12 months. It will be both colposcopy and cytology if less than 25, but if she's more than 25, not only cytology, it should be with HPV testing. Then we have the management of, we'll not go detail on it, just patients when she will come with the adenocarcinoma in situ, we should do for her excision. Always we should do for her excision to rule out invasive cancer, occult invasive cancer, because the management totally will be different. It will not be simple hysterectomy. So even if the margins, they are not clear, we have to re-excise to be sure that there is no cancer. This is also if the patient's emphasizing again, if she needs definitive hysterectomy in adenocarcinoma in situ, we have to do the excisional procedure, and the specimen is accepted to be 1 centimeter, 10 millimeter. It is accepted. How about in pregnancy? And if patients during pregnancy, she had colposcopy and it was high grade, do I delay for her or can I manage her? That question comes. This is one. Second thing, colposcopy to be done in pregnancy, it is difficult. We need an expert because already cervix will be changed. So we have to know the changes, physiological changes of the colposcopy. So it is required if she was high-grade cytology. So we do for her colposcopy testing is accepted by 12 and 24 weeks in pregnancy. But is also we can delay it after delivery. It is not wrong to delay the patient. And during colposcopy, if we find that there is a suspicious area or there is for cancer or lesions worsening, we can take biopsy. For postpartum, what is the ideal time to do for her the colposcopy postpartum is 4 weeks. And this is my last slide. Yes, I hope everybody lives long life, yani. Nowadays, we are seeing so many cervical cancer, but is coming more in non-Bahraini rather than in Bahraini. But it's, actually, still I don't have the statistic. But there was a study done, I think, by KHUH done study. Yes. Dr. Ghufran and Dr. KHUH, they did.
We have a textbook regarding the colposcopy. We have a very good colposcopy unit.
I read it, yes.
Yes, excellent colposcopy unit in King Hamad University Hospital, and we have many studies regarding that is the cancer cervix and the management and the pap smear. But I don't think that we have here national guidelines.
No, we
and
don't
we have to have a national guidelines and us instead of us, because it depends on the cultures and the characters of our patient. The second point regarding that is what's the difference between high-grade squamous intraepithelial lesions and CIN2, CIN3. I think because a little bit you mix it between both. If you are saying high-grade squamous intraepithelial lesions, it is a cytological diagnosis. But when you are saying CIN2, CIN3, it is a histopathological. Most probably you did a colposcopy or you took directed biopsy.
This is the CIN2 and 3. It is based on colposcopy, or sometimes we have what we call, I didn't keep it.
No, we cannot diagnose this.
No,
we cannot diagnose this.
We have what we call last terminology, lower anal, and it divides to low SIL and high SIL. And if they labeled as a high SIL, it is recommended by the ACCP to mention, because the management will be deferred to mention, is it high SIL? Yes, I'm agreeing with you, it's a cytology, but they also, not cytology, biopsy. It should be like written high-grade SIL, CIN2, or high-grade SIL, CIN3.
I do agree with you, but it is, again, we have to differentiate between abnormal colposcopic finding, between the cytological abnormality, high-grade,
I mean,
and that is CIN3.
Yeah, but here estimation risk, the patient still, she did not get CIN. We are estimating the risk that she might get the risk of CIN3. We did not confirm. The statistic, I understand, the pathology, it will give us the CIN3. But here when I'm talking, not the pathology, I'm talking about the biopsy of, you mean which slide? I confused. The estimation risk CIN3, 4%?
You mentioned it after the other side, the other slide.
Which is because we are talking about the calculating risk, CIN3 for the cut point 4%, It is not cytology. And it is still the patient.
I'm not criticizing you.
No. Just
It's
explain
okay.
if there is a confusion. No, no. It is the patient she will get. She will get. So what is the management for her? Do I have to do for her colposcopy or if I estimated the rest? Still, she did not get. But when I talk about the fertility, CIN2, no, it is confirmed. Confirmed that
This
she
is
is
regarding the
CIN2.
fertility also.
Yes.
That is the definite, the hysterectomy is not the definite treatment of adenocarcinoma in situ. This tells you how you can do it as also trachealectomy or high conization.
Yes.
Okay.
See, I mean
just one small thing, because I know that during pregnancy, there's no contraindication for directed colposcopic biopsy.
No.
That's during pregnancy.
No.
Yes, I do agree with you.
But
even conization.
Yes, even conization if she needs. They wrote
Yes, of course.
If you feel you don't, she can defer or to be delayed after delivery. We can wait. No problem.
Conferences from these hot discussions, and still we will have talks about the cancer cervix with Dr. Mahmoud in his talk, I think tomorrow. So, but now we will listen to Dr. Mahmoud Sami, Professor of Ops and Gynae in Egypt and in Berlin and in Bahrain. And he's a dear colleague of me for the last 30 years, since we were junior consultants. And we will hear him now in his presentation. Dr. Mahmoud, the floor is yours.
Good morning again. As our protocols in King Hamad University hospitals, you have many publications, and we decided that this is the senior one who has or shares or supervising any studies. So let the juniors colleagues to study that. All our publication, which will be today, now and in the next session, has been published in the international journals. Dr. Adina Said is our registrar. She's very active. She conducted the study about vitamin C and the calcium, about the mode of the deliveries in our hospital. She's welcome.
Thank you. Assalamu alaikum. Good morning, everyone. It's a great honor for me to get me a chance to present here in this Congress. My name is Dr. Dina Said. I was working before in Bahrain Specialist Hospital, then King Hamad Hospital till beginning of 2021, then now in Salam Specialist Hospital. Our research is about the effect of maternal vitamin D and serum calcium level in mode of delivery. The research was published on 2022 in Sarahwaya publication. It was done by me and my colleagues, Dr. Sabita Al-Ajen and Dr. Nawal Abdullah, under supervision and guidance of Professor Mahmoud Sami. The study, the aim of the study is to detect the relationship between vitamin D and calcium levels on the mode of delivery. As we know, vitamin D is an essential nutrient that is required for bone growth, mineral metabolism, and calcium homeostasis and cell functioning, and it's responsible for calcium and phosphorus absorption from the gut and resorption of calcium from the bone, and to maintain calcium and phosphorus homeostasis and bone mineralization. Vitamin D deficiency is a common in pregnant women and play an important role in calcium homeostasis. The vitamin D stores in an infant at birth depend on maternal vitamin D status during pregnancy through transplacental transfer of vitamin D in the form of 25-hydroxycholecalciferol, and the reported prevalence of vitamin D deficiency in exclusively breastfed infant range from 27 to 82%. So pregnant women are considered at a high risk of vitamin D deficiency. And as a result, children with minimal exposure to vitamin D are at a higher risk of developing health problems. We designed a single center retrospective cohort study at King Hamad University Hospital with criteria selection. The inclusion criteria, the participants were at childbearing period from 18 to 45 years old with a singleton pregnancy at term who delivered in KHH in duration of 6 months in 2021. We excluded any patient with positive medical history like diabetes, hypertension, thyroid disease, renal or liver disease, and any patient with a history of previous cesarean section. As we know, there is a causal relationship between the primary and repeated cesarean sections. 1 or 3 patients met the inclusion criteria. Data was collected retrospectively from the medical record of the hospital, including the labs of vitamin D and serum calcium level and mode of delivery. The data was analyzed using its statistical package of social and science. Descriptive statistics were used to compute the frequencies, median level, and interquartile ranges. Results of the study. In the study, we found that vaginal delivery was the most common mode of delivery among our participants. 17 cases only went for cesarean section and only 2 cases for vacuum delivery. Vitamin D and calcium level versus mode of delivery, vaginal delivery or cesarean section. We found that participants who delivered vaginally had a median of vitamin D level of 11.8 nanogram per milliliter, and who went for cesarean section who have vitamin D level were 11.2 nanogram per milliliter. And level of calcium level for participants who went vaginally and cesarean section delivery were similar at 2.2 millimole per liter. Ready vacuum delivery represented a smaller sample size, however, vitamin D levels in with vacuum delivery cases will reach 16.2 nanogram per milliliter and calcium level 2.3 millimole per liter. We found that there is no statistical significant association between the mode of delivery and vitamin D and calcium levels in our study. However, there was a lot of studies before, like Merwed et al. Found that women with a severe vitamin D deficiency were 4 times more likely to deliver through cesarean section than those with adequate vitamin D level, and those with the highest serum vitamin D levels and the highest chance for undergoing cesarean section. Any question? Thank you.
Nice president. Wait, one question. Do you think if I improve the vitamin D and calcium level, the mode of delivery will change?
Some studies saying that if we improve the levels of vitamin D and calcium, the risk of cesarean section will decrease.
Yani I have to estimate the level of vitamin D and calcium at the beginning of the antenatal period so that
we need to increase the awareness
so that I have time to raise it if there is any deficiency to avoid going for cesarean section. Okay, thank you.
The next speaker, Dr. Nahid Kamal. Dr. Nahid is a consultant OBGYN, fetal-maternal medicine, and PhD, RCSI senior clinical tutor in Salmania, Dr. Nahid. Yeah, welcome. Yeah, well,
hello, everyone. It's a pleasure to be with you today, and I'll speak with you about the fetal thymus and the preeclampsia. This is actually my study and my research was being done when I was doing my training for fetal-maternal medicine in Australia. And this research was awarded for the best research in University of Sydney for Nepean Clinical School. Okay. Sure. You don't have it? No, I give it to Ahmed. No. No. Sorry for this. Sure. This one? Can you teach me how to do this? Not the other side. Okay. Let's start. This is just for fun. Okay. So, baby born in high-tech hospital usually comes cordless. No. Can you see this one? I want to go to the previous slide where I missed it. Yeah. Maternal immune system learns to accept fetus during pregnancy. A separate immune system began to develop in the growing fetus. Although the mother and the fetus are separated by the placenta and the fetal membranes, they are closely linked physiologically and metabolically. Okay. Fetal immune. This is moving by itself. Anybody pressing it? No, it's moving by itself. Okay. Fetal immune programming infers that during pregnancy, the maternal immune has a significant impact on the fetal immune system, affecting long-term fetal health outcomes. Like what? Like in case if I have a case of growth restriction, like an IUGR,
This is during the pregnancy, and this is will influence like a patient. What is the cause of the IGR? Maybe hypertension, maybe anemia, malnutrition, but this will have an impact later on, like increases the risk of having non-communicable diseases, like later on for our offsprings. They will have diabetes, they will have cardiac diseases, and stroke. This is the effect of the immune happening later. Okay. So the immune system to serve and to protect. So from the immune system, we have the thymus. The thymus is the lymphoepithelial organ, and its morphometry is commonly utilized for surveillance of the immunological status of the fetus and the neonate. Okay. So I will see the fetal thymus here. Yeah. The thymus is a bilobed primary lymphoid organ. It has significant role in the differentiation, selection, maturation of the T cell lymphocyte. The development of the thymus begin in the 5th weeks of gestation, and it comes from the 3rd pharyngeal pouch in the ventral arc, and the lymph part, and the lymphocytes start to form in the thymus from the 9th week of gestation. The thymus grow and enlarge continuously from the prenatal period and to the puberty. The thymus has an effective response to the systemic fetal inflammation during the prenatal period. The stress convulsion might appear during the prenatal phase in response to different forms of acute stress stimuli such as infection, trauma, sepsis, and malnutrition. The current literature identifies fetal thymus size as a sensitive prognostic tool for pregnancy-related disorder. So they are using it for the eclampsia, for preterm labor, choriamnitis, with or without premature rupture of the membrane, and the gestational diabetes. Preeclampsia. Preeclampsia is the leading cause of morbidity and mortality in pregnancy worldwide, a disorder unique to human pregnancy. The exact etiology of preeclampsia remain unknown. Nonetheless, failure of maternal fetal immune tolerance frequency cited. Specifically, the maternal immune response directed against the fetal graft are thought to inhibit the embryonic implantation. The ultimate outcome of being in the placental insufficiency, actually, the pathognomic feature of a preeclampsia. The immune tolerance is mediated by the thymus T cells, the lymphocyte, and particularly the regular T cells. So in healthy pregnant women, how it will happen? Like healthy pregnancy, the ratio between the T cell and the pro-inflammatory T cell will increase. And this is what shows that there is tolerance, immune tolerance, okay? But in preeclampsia, changes do not occur in preeclampsia. Okay. The exact etiology of preeclampsia remain unclear. So let's see the definition of preeclampsia. Preeclampsia is the hypertension with proteinuria at 20 weeks with the heterogeneous high variable involvement of the maternal brain, liver, kidney, and coagulation system, and the fetal placental unit. Okay. But it is known to involve immunological factor based on the rejection of the fetus by mother, as well as a vascular process associated with poor placentation. The primary immunological dysfunction is associated with widespread change in the composition of maternal thymus-derived T lymphocyte and the rise in the inflammatory marker like the tumor necrosis factor. In this picture, you can see the image of the fetal thymus. I like my scan actually. This is a beautiful fetal thymus, and we use the transverse diameter. You can see here, I shaped the whole thymus. It is in the level of the 3-visual view during the fetal echo, and it is between the mediastinum and the vertebra. And you can see the beautiful thymus is there. We measure it using the transverse diameter, okay, to see if it is involuting. Now, with more researchers, they are using volume 3D, but the most have been used was the transverse diameter for the involution. Okay, so why the fetal thymus? There is like in perinatal pathology, we have another different organs can be affected, like the liver, kidney, and adrenal gland. But these organs are really like be steady affected, or they are be like least affected with the immunity and the nutrition, but especially after 20 weeks. But the thymus, no, it will be more affected and with the immunity and the nutrition. So fetal the involvement to investigate involvement of fetal adaptive immunity in preeclampsia, we studied gross morphology of the fetal thymus when you use the ultrasound. Preeclampsia. Preeclamptic women had more preterm deliveries, we know all of this, higher rate of antenatal steroid use, infant with smaller birth weight, and increased admission to neonatal intensive care. All findings that are consistent with the natural history of preeclampsia. Unlike other conditions linked to fetal thymus involution, preeclampsia lack an obvious stimulus to cross the placenta and activate the fetal hypothalamic pituitary axis. As such, increased transfer maternal cortisol is a more intuitive mechanism for the fetal thymus involution in pregnancy. Nonetheless, fetal thymus involution has been documented in chorioamnitis in the absence of demonstrable infection, thus through a secondary mechanism yet to be discovered. Maternal inflammatory mediator alone may be capable to triggering fetal thymus involution. In our study, we have demonstrated that the smaller fetal thymus is a feature of a preeclampsia, independently of the coexistent small for gestational age or antenatal steroid use. Furthermore, we have provided preliminary evidence suggested that a smaller fetal thymus precedes clinical disease in preeclampsia. This later analysis, although statistically significant, is nonetheless limited by small group size. As such, precisely which event a small fetal thymus or clinical preeclampsia occur first remain uncertain. In many cases, since the thymus is essential mediator for the T-cell immunity, fetal thymic changes in the preeclampsia may have long-term immunological consequence for the child. So I will never forget you because it will be for the child for a long time. Okay. The thymus, again, the thymus is primary center for T cell differentiation and therefore a critical component of the immunotolerance. A lymphoepithelial organ located in the anterior mediastinum. The thymus undergo physiological atrophy during adolescence. So after adolescence, the thymus will start to have atrophy. Alternatively, involution of the fetal thymus can occur in utero in association with estrus during pregnancy, a non-specific phenomenon probably mediated by excess cortisol. Fetal thymus involution is documented in the choriamnitis and fetal inflammatory syndrome, and recently that's the observed small fetal thymus in the preeclampsia. We also discover that small fetal thymus size in several healthy women later diagnosed with preeclampsia, hence suggesting small fetal thymus may precede the clinical disease. Clinical signs of preeclampsia typically presented in the third trimester, though the initial pathologic changes likely occur much earlier during the first trimester. So this was the hypothesis. Then we did another study, like we measure in the mid trimester, we measure the thymus to see if it is really will have developed later on preeclampsia, and it was also there is significant finding. Okay, what is next? Okay, we are speaking about thymus, so we can measure if there is any immunity defect, and it can help us like by just measuring this organ in the fetus, and for the future we can have to know about the outcome of our babies. What is this? What can we do more? In view of COVID and the effect of the COVID for our pregnant ladies and the fetus, we don't know what could happen in the future. But it's a tool also that we can measure the fetal thymus to see if this can affect the immunity of the baby for the future, for the non-communicable diseases, like the IUGR. It's normally with the IUGR, the fetal thymus will be smaller. So later on, they develop stroke, cardiac disease, diabetes. So we have a tool to measure it for the immunity to see about the thymus for the COVID. I think this is a project for the study, what we are going to do to see the effect of this COVID in the future of spring. And I will be happy like if it will be like a national study, because like all of us will go through this, and just we need to train how to measure this thymus and do it. So it just needs us to start this. Okay, thank you for listening. Okay, and this is the reference for the study. Actually, I didn't give you say only my study. I just went through the other studies too, for that I was reading, because other studies in between my studies.
Okay. Thank you very much, Dr. Anayat, for this excellent presentation. And actually, this is any presentations coming from a study or research it is a very valuable thing. I think this is, we are proud of you. It's okay. And we are reaching the end of the session, first session. And my thymus has been affected by the cold. And I don't know, it is related or I have a small thymus, I don't know.
It's already shrank.
It's shrank it already, thank you. So I will go again in the fetal age. Okay, we will have 10 minutes for coffee break, 15 minutes for coffee break. Thank you very much.
lecture. The first lecture. Okay.
I touch it direct.
أو ممكن هذا التاتش أو الأفضل إنه نستخدم الكليك. هسه هذه كنترول من عندهم بس من تبدأ المحاضرة. We will start now the second session, and for those who are willing to attend the pediatric, it will be on the second hall. So this is for the obs and gynae, and the second hall for the pediatric.
Good afternoon, everybody. First, I'm Dr. Fadila Najjar, working in Al-Kindi Specialized Hospital. First of all, I would like to thank the organizing committee, Dr. Muhammad Salman, Dr. Hatem, for giving me this opportunity to give my talk today. And my presentation will be about abnormal uterine bleeding. Before I talk about the etiology and the other parameters of my subject, I will present three cases, which is a common presentation of abnormal uterine bleeding, which we usually encounter in our daily practice. So the first case is a 14 years old young girl. Her BMI was normal, and she started menarche before 13 months. And she complained of heavy vaginal bleeding in 17 to 14 days duration, and the period is a long period, 18 to 40 days. And because of the heavy bleeding, she's tired, anemic, lightheaded, and dizzy. The other case, it represents a reproductive age group, 35 years old, obese woman, complaining of a regular period in the last 3 years, and she had the 3 to 6 periods per year only, and her period usually lasting up to 10 days. Her most recent period was 4 months back, and she had moderate amount of acne and facial hair. The third case is postmenopausal bleeding in a 53 years old who never been pregnant, and she is type 2 diabetes, hypertension, and she have also obesity with a high BMI. Her period was regular until it stopped in the last 4 years. Her past 6 to 8 months, she encountered irregular bleeding every 30 to 45 days, and it lasts up to 7 days. She doesn't have any family history of a breast or GI or genital cancer, and her physical and physical pelvic examination was negative. This is a common presentation. We usually see them in our daily practice, which give us differential types of abnormal uterine bleeding. So before I talk about the abnormal uterine bleeding, let us know what is the normal menstrual cycle. All of you, I think you know this, that the FIGO classification came in 2018 with a new classification of frequency of period should not be exceeding 38 days window. The regularity cycle to cycle, it should not exceed nine days, and the duration of a flow 4 to 8 days, and the amount of blood not more than 80 ml. Sorry. The early classification, which we are used before in the past, which is mainly rely on the bleeding characteristic, not in the etiology of abnormal uterine bleeding, and it should be abandoned because a new classification came and it is more accurate in diagnosing a patient with abnormal uterine bleeding, you know, menorrhagia and metrorrhagia, oligomenorrhea for a short infrequent cycle, and polymenorrhea for a more frequent cycle with dysfunctional uterine bleeding, which we call it DUB, after exclusion any pelvic or underlying medical cause, which is usually involve different types of characters of abnormal uterine bleeding. In 2011 came a new classification by the FIGO. It is abnormal uterine bleeding, which is defined as a changes in the menses frequency, regularity, duration, and amount of blood loss. And there is two types of abnormal uterine bleeding. It is either acute, which is a heavy bleeding, which need immediate intervention, or a chronic bleeding, which is usually occurred in a 6-month duration or more. And the FIGO included also the terminology of abnormal uterine bleeding is a heavy menstrual bleeding, intermenstrual bleeding, unscheduled bleeding, and a breakthrough bleeding, which is related to hormones. The epidemiology, the prevalence of abnormal uterine bleeding, it is difficult because not most of the women will seek medical treatment, and the component also of diagnosis, it is objective, and some others are subjective, making the prevalence is difficult to determine, and usually it reaches up to 30%, and the higher incidence, it is in the extremes of reproductive age, early menarche, and near menopause, which may reach 35% and more. I will go through a quick revision on the physiology of menstruation. All of you know that the cycle is controlled by the hypothalamus, anterior pituitary, and then the hormones here. We can see the LH hormone affecting the proliferation with the estrogen, proliferation of the endometrium, and then it surge, and the progesterone, it will be secreted, and this progesterone will stop the proliferation and will cause differentiation of the cycle of the endometrium, especially the functional and basal layer of the endometrium. When the progesterone fall with the ovulation, this lead to enzymatic breakdown and the functional layer, and this lead to a blood loss, stuffing, which make up the menstruation. So if we want to have a regular cycle, we should have a functional platelets, thrombin, vasoconstriction, normal uterus, and normal coagulation, and endocrine system as well. So any derangement in the uterus by the leiomyomas, polyp, adenomyomas, malignancy, or hyperplasia, this will lead to abnormal uterine bleeding. And if there is any disruption in the coagulation or coagulopathies or iatrogenic or the hypothalamic pituitary axis, it will affect also the menstruation. and the patient will end up with abnormal uterine bleeding. So abnormal uterine bleeding, it is a problem for the woman because it affects her social, psychological, quality of life. It may lead to her absenteeism in her work, in her school if she's young, limitation of their activity, and if it is very heavy, it may lead to anemia, pain, sometimes dysmenorrhea, and she may end up with surgery and hysterectomies. So the goals of the treatment is reduction of menstrual flow. We have to reduce the morbidities and improve her quality of life. On this classification, the Palm and Coin classification, which is came by the FIGO as well, it simplified for us as a gynecologist, obstetrician, physician, to lead us to the diagnosis of abnormal uterine bleeding by following the Palm and Coin classification. PALM classification, which usually the lesion can be examination or by any imaging technique or by the histopathology. And it is the examples is polyp, adenomyosis, leiomyoma malignancy, or and hyperplasia. And the coin, which is related to components which is not visualized by during examination or by the aid of any imaging technique or by the histopathology, which is related to coagulation or for ovulatory disorder, and E for endometrial changes, and I for iatrogenic with the IUCD, and N is not classified yet a group. So I will go through each type, and we will see together the diagnosis and treatment. The polyp, you know all that the polyp, it is very common, and we are usually see a lot of patients comes in the clinic with the polyp, and it is a common problem. It is due to proliferation of the endometrium gland and stroma. And most of the patients, we just discover it during examination and they don't have any symptoms, but some they will come with vaginal bleeding, and the incidence of polyp, it increases with the age, and usually it can be coexist with the fibroid during examination. Most of the endometrial polyp are benign, but in a study of more than 10,000 women by the Ferraz and al. In 2010, they found that there is an incidence of malignancy 1.7%, and the risk increase in postmenopausal women, it may reach to 5.47, so don't ignore polyp during your evaluation. The risk factor, advanced age, tamoxifen use, high level of estrogen, obesity, and it could be part of patients who have family history of Lynch syndrome. They are at a higher risk of polyp formation. And the other type of polyp is the cervical polyp. It is occur most in the reproductive age, especially after the 40s, and it is usually arise from the endocervix, and it is caused by inflammation and hormonal factor. It reached 3 centimeters, but even more. Sometimes we see more than 10 centimeters. I remember I saw one patient, she came with something protruding, referred as from the health center as a uterine prolapse, but when I examined her, I found this is a cervical polyp, which was protruding from the introitus. And usually it is not malignant and can be easily removed in our clinics, in an office. Okay, the diagnosis of endometrial and cervical polyp. The ultrasound, transvaginal ultrasound, it has a high sensitivity and specificity. It reached up to 90%, but with the saline infusion, it is more specific and more sensitive for the uterine and endometrial polyp. Hysteroscopy, diagnostic hysteroscopy also, it has a higher sensitivity and specificity, and the hysterosalpingogram, it is less. And then the benefit of transvaginal ultrasound over the saline infusion, that we can see also the ovaries and tube. And usually we can do it, the cervical polyp in the clinic by hysteroscopy. The other type of abnormal uterine bleeding is the adenomyosis. Adenomyosis, you know, this is an endometrial gland and stroma which present either focally or globally inside the uterine musculature, and it is causing hypertrophy of the muscle surrounding it, and it has a higher prevalence from 5 to 70%, and usually in the woman in their fourth decade and more. The symptoms, we always see patients with adenomyosis, and I think most of them, they will be symptomatic, but there is also a group of patients which they don't have symptoms. They encounter 1/3 of the cases, and usually when they have symptoms, it is mainly heavy menstrual bleeding, dyspareunia, dysmenorrhea, irregular bleeding, and there is an evidence it is related due to abnormal gene, and usually it runs in the family. The diagnosis, we do diagnosis by the transvaginal ultrasound or by the MRI, and it has different presentation. By the ultrasound and MRI, we can see it as an echogenic striation. It could be a myometrial cyst. There is this configuration. It could be symmetrical or asymmetrical, and the thickening of the myometrium. And there is poor differentiation. Sometimes it can be mistaken by the endometrial cancer because of poor differentiation of the endometrial myometrial interface, and it could be focal or diffuse. The treatment is to suppress the hormones by either using high dose of progestin or serum or the SPRM, or using the levonorgestrel, hormonal IUCD, gonadotropin receptor agonist or antagonist. Endometrial ablation, it has a higher failure rate, 30%, and the UAE, the uterine artery embolization with the magnetic guided focus ultrasound, it is very promising in this field. I will talk in details later about all these treatment modalities for adenomyosis. The next common cause of abnormal uterine bleeding is the fibroid leiomyoma. You know, leiomyoma is rising from the smooth muscle of the myometrium, and it develops especially during the reproductive years, and most common, it is a most common pelvic tumor, and it has a prevalence of 70% in the white woman, and it is increased in a black woman. The risk, it is more in African American race, early menarche, early using of oral contraceptive pills, and low parity obesity. Diet also, it's been as a risk factor, especially those who increase consumption of meats, high consumption of alcohol, hypertension, and if there is family history of fibroid, usually the daughters, they will have it if the mother positive for fibroid. Symptoms is very common: painful menstruation, heavy menstrual bleeding. If it is large enough, it may cause a pressure symptoms to the pelvis. It may lead to urinary frequency, urgency, bowel symptoms, and affecting the reproductive and future of fertility of the patient. And if it is big enough, the patient may have obstetric complication and during even delivery. Here, the classification of FIGO by the ultrasound from 0 to 7, and they depend mainly on their present. And this is very important even when we send the patient for highlighting. You can see the 0, which is pedunculated, and 2, 1, it is mainly in intracavity 2, it is partially or more than 50% intramural. Here it is just attaching the metrium. 4, it is intramural, and 5 mainly subserous, and 6 it is more than 50%, and the other is pedunculated, and it could be also broad ligament or cervical fibroid. This classification is very good because we can schedule our surgery, especially for those who have submucosal fibroid, if we can remove it by the hysteroscopy or other technique. The treatment, if the patient asymptomatic, usually we don't treat unless she have infertility and it is distorting her uterine cavity. But if the patient have heavy menstrual period, usually we give a tranexamic acid, contraceptive pills, hormonal IUD, danazole, the same modality of a treatment for adenomyosis. Tranexamic acid, all of us have experience using tranexamic acid for controlling heavy menstrual bleeding. It reduces the fibrinolysis with a short half-life, and usually it is used in cases of hemophilia, cause or van Willebrand coagulopathies related to abnormal uterine bleeding, but we use it also as a first line measures for heavy menstrual bleeding. And there is different dosage internationally according to different places. Like in Sweden, they use 1.5, in Europe, 1 gram, and in the States, it is 1.3, and usually it reduces the amount of blood loss up to 50%. Tranexamic acid, we should use it with the precautions, especially with patients who have a history of venous thromboembolism or cerebrovascular disease. It may cause thrombosis. So we have to use it with care. The OC pills also helping in reducing amount of bleeding up to 72%. And it is a very therapeutic option. It is a very good therapeutic option for cases without structural change. And it could be given cyclic or with pauses. And usually the ethinyl estradiol with levonorgestrel is a good choice. Both combination, good choice for treatment, and other also will be fine. This is another formulation with Dianogist. Also, it shows its efficacy in treating patient with abnormal uterine bleeding. The GnRH, this is very old. I remember since we were junior even, and it is very effective and enable to reduce the volume and if the other hormonal treat methods are contraindicated, but its limitation of its use due to the side effect of osteoporosis and hot flashes. The selective progesterone, this is a relative new class, which is composed of mix of agonist and antagonist properties, mifepristone, ulipristal, and valipristone. It's been used in all Europe, I think, since maybe 7-8 years, but still it is not licensed but in Middle East. And mifepristone, we have all used it for abortion, for bleeding, for induction of labor, and endometrial cancer. And the valipristone is still under study. But the ulipristal acetate being used in Europe, and even it was well tolerated for cases of emergency contraception, and it is very effective in reducing the size of fibroid. But the problem with this is liver toxicity. So the EMA announced restriction of use in Europe. They have withdrawals from the market because of the liver toxicity after using the ulipristal acetate. And there is just, there is consider ulipristal for a few cases, which they are perimenopausal, heavy menstrual bleeding, if the fibroid is small, 3 centimeter or low, and just to improve the patient hemoglobin before surgery. The new drug which came to the market recently is the GnRH antagonist, which antagonize the gonadotropin releasing hormone. It is a novel drug since 2015. Some of them, it is released in the market and it shows its efficacy in treating endometriosis, leiomyoma, and adenomyosis, especially for the heavy bleeding and reducing the size of the fibroid. And I think the linzagolex, which is orally administered and we can control the dose, it is released in the market for controlling the pain of endometriosis, and it shows its efficacy. But for adenomyosis, it is still under the study in phase 3, and it shows it has a less side effect of GnRH agonist, but the osteoporosis which may happen, it can be overcome by add-back therapy, estrogen, progesterone. And this is announced recently by the American College of Obstetric Gynecology in May 2022. The levonorgestrel is, according to the NICE guideline in 2021, they consider it as a first-line treatment for patients who have no identified pathology or they have a small 3 centimeter fibroid, which does not distorting the uterine cavity, or if she have adenomyosis. The surgical, all of you know this, submucous fibroid, we can remove it by hysteroscopic myomectomy. Endometrial ablation, if the cavity is normal or a small fibroid, even we can remove the fibroid, and then we do with different generation of endometrial ablation, or in conjunction of hysteroscopic myomectomy, and also uterine sparing option, which is the uterine artery embolization, laparoscopic radiofrequency ablation, and they found that reintervention of abdominal myomectomy is 1.2, while with the UAE is 7.4, and 34% with the high intensity focused ultrasound, and 3.2% recurrence of the fibroid after hysteroscopic myomectomy. Malignancy, it is another cause of abnormal uterine bleeding and pre-malignancy condition. It is usually a malignancy of the vagina, uterus, or the cervix. It contributes in abnormal uterine bleeding, and it is very important if patient suspecting malignancy or patient have heavy menstrual bleeding with a high-risk age group, we should go for pap smear and a screening of the tissue. And usually the female, she has a risk of developing endometrial cancer, 2.8%, and 70% of the cases can be diagnosed early, and especially because of the symptoms. Usually the patient who have malignancy, they will come with abnormal uterine bleeding, and so this will lead to early diagnosis unless the patient neglected. And different type of malignancy, I will not talk in details about it. I think you will have a lecture later. Endometrioid, which is the commonest, papillary serous, clear cell, and carcinosarcoma, which is more aggressive, a tumor. And the risk factor, all of you know that unopposed estrogen, or especially in the obesity, diabetes mellitus, patients who have hypertension, nulliparity, and tamoxifen use. The Lynch syndrome also, it gives a higher risk for a patient. It reached up to 71 lifetime risk of endometrial cancer. Management of endometrial cancer, or in general, any patient with a high risk of malignancy who have heavy menstrual bleeding, we should not go for the blind endometrial biopsy, and we should not do the DNC, dilatation and curettage alone without hysteroscopy. This is according to the NICE guideline in 2018. Endometrial biopsy can be considered first-line treatment for patients who are above 45, but those who are younger than 45, who are which have unopposed estrogen exposure and obesity, PCO, or after failure of a treatment or persistent bleeding, they should have also endometrial sampling. The management of cancer, the pebbles also sometimes we do only endometrial biopsy in the clinic by using the pebble. It has a sensitivity or diagnosis for endometrial cancer is 91, and for atypical endometrial hyperplasia is 81%. And this hysteroscopy, of course, it is more sensitive and specific and diagnoses endometrial cancer or abnormal endometrial hyperplasia. It reached to 99, 96 according to the American College guideline. And endometrial intraepithelial neoplasia, it could be treated without atypia by oral progesterone or by inserting only the hormonal levonorgestrel IUCD. And the patient usually will need a follow-up with the endometrial biopsy. And for malignancy, of course, hysterectomy. This is the progesterone and its effect. I will not talk much about it, so I can focus also on the other slides, the coagulopathies, as usually we neglect this part of a classification, and it should be focused during our history taking when the patient come. There is two types of coagulopathies which is encountered for abdominal uterine bleeding: the inherited Van Willebrand disease, which make about to 24% of women with heavy menstrual bleeding, and it is due to factor 8 and 9, which is more common, and factor 7 and 11 also, or platelet disorder. And the acquired coagulopathy in patients who have leukemia, aplastic anemia, renal or liver disease, or failure, sepsis, DIC, excess use of non-steroidal anti-inflammatory herbal remedies, anticoagulant, and the chemotherapies also expose the patient to abnormal uterine bleeding. So it is very important when we take a history, it should be structured, and we should exclude the coagulation defect. So it is very important to ask the patient about her menarche and if she had a heavy bleeding during menarche, and we should ask also at least one of these following about her postpartum. If there was a bleeding, if she was bleeding during her surgeries, or bleeding associated with any dental work. And two or more of these followings, it should be, we should have the suspicion of coagulopathies. If the patient develops bruises once or twice per month, epistaxis once or twice per month, and the frequent gum bleeding, if she have a family history of a bleeding disorder. All of you know that what we do for a patient who have coagulopathies, CBC, platelet count, prothrombin, and activated partial thromboblastine, plasma for Van Willebrand antigen, and the activity where ristocytine cofactor, and the other factors for coagulation. Management, we have to, for the inherited coagulopathy, we have to replace the factor deficient, desmopressin, hormone therapy, and the conjugated equine estrogen is helpful in controlling bleeding with coagulopathies. The acquired also, they will take it in a higher dose, usually for the first 24 hours, and the combined OC pills also effective in reducing the heavy menstrual bleeding. And medroxyprogesterone, tranexamic acid, sometimes a patient can go for endometrial ablation or uterine artery embolization. And ocipos also, it has a higher efficacy in controlling coagulation. It reaches up to 88%. And the estrogen medroxyprogesterone acetate also, it is very effective. The other types of abnormal uterine bleeding in the classification is the ovulatory dysfunction. Ovulatory dysfunction means that not ovulating or having a regular basis of or infrequent lead to amenorrhea. Usually irregular bleedings, they may encounter irregular bleeding they will have usually occurs in the early reproductive years and in late perimenopausal. And the episodes of bleeding, it is varied, either it is light bleeding or heavy bleeding. The pathophysiology, I will just pass it because all of you have faced this, and it is typically the first case or second case which I encountered in my presentation. The risk factor for ovulatory dysfunction is the polycystic ovarian syndrome, obesity, hypothyroidism, hyperprolactinemia, anorexia, extreme exercise, and significant weight loss. And management, we should identify the cause and treat it.
2 minutes remaining,
Yeah, I will just pass this slide, and then the endometrial. Here, the causes, if it is not management, it is the same, and the surgical management also for the iatrogenic. It could be from the hormone or from the steroids. Sometimes when we give the patient, they will complain of breakthrough bleeding from any contraceptive or hormonal treatment, even antidepressant or anticoagulant. Okay, and the management, we give estrogen in continuous. Usually in this situation, the patient will have breakthrough bleeding, and usually we correct it with low dose of estrogen if she have progesterone, or a short course of non-steroidal or deoxycycline if it is the cause is endometritis. Just I want to highlight on one thing here in this category of abnormal uterine bleeding is not yet classified. We miss it sometimes, the atriovenous malformation or myometrial atrophy. And with the increased number of cesarean section and repeated cesarean section, we are encountering cases with the uterine ethmoseal, or we call it niche, the cesarean niche. It is indentation of the endomyometrium inside the scar, and it will collect the blood inside. The patient will come with a history of a prolonged period. She will say that I was having 7 days period, and after cesarean, I'm having now 3 days spotting post-cesarean, post-menstrual. So it is very important when we do an ultrasound, we have to go to the to her cesarean scar and look for these niches, which can be easily corrected hysteroscopically or with the minimal invasive technique. Myometrial hyperplasia and endometritis, which can be, I will pass these. Estrogen precautions and acute and the chronic treatment of, I will go to the conclusion. After complete, it is very important to keep in mind, and we have to abandon the previous classification. After complete history and examination, we exclude the pregnancy. We have to start our assessment of any abnormal uterine bleeding using the palm and coin terminology. Ultrasound, it is available in all the clinic, and it is a very diagnostic tool, and it is the first line investigation we can consider, and consider the hysteroscopy for any patient who have heavy menstrual bleeding, guided by biopsy. And the management should be directed to the etiology to improve the quality of life, and we should not miss modification of the her behavior, stress reduction, weight reduction, and exercise also we have to focus it and advise it to the patient when they come with abnormal uterine bleeding. Thank you very much. And if you have any question.
Thank you, Dr. Fadila, for the informative presentation. It is really a hot topic that we face in the clinic every day. About more than 30% of our consultations are of abnormal uterine bleeding. If any questions from the floor, please.
Actually, it is not available in Asia. Still, it is not approved. But according to the literature, which I review for the presentation and what I read it before, the oral, you can control it, and even the use, usually they don't give a higher dose. They started with 100 milligram, and they control it, and they count also, they follow the side effect. If there is side effect from this drug, they can stop it, and it reduce the size. They have tried on endometriosis, and I think it is launched in the market in other countries. I'm not sure. In Turkey, I think they use it also, and it shows its efficacy, and even the side effect, once they stop it, the side effect will disappear.
Any further questions? Okay, thank you very much, Dr. Fadila. We can move to the next presentation.
The next presentation will be by Dr. Sina Al-Mansouri. Dr. Sina Al-Mansouri, she is a senior consultant on obstetric and gynecology, specialized in minimal invasive surgeries in gynecology. She is MBBCH and Arab board certified, fellowship in minimal invasive surgery, Egypt and Clermont-Ferrand, France, and European University Diploma of Gynae-Operative Endoscopy by the CICE France, and she's a senior consultant in Salmania Medical Complex till 2017, RCSI senior clinical tutor till 2017, senior consultant in King Abdullah Medical Center till 2021, and currently she's a senior consultant in As-Salam Specialized Hospital and Eva Medical Center. You have the talk.
Thank you very much, Dr. Fadila, for the kind introduction. Can you please start? So today I will talk about challenges in laparoscopic hysterectomy, tips and tricks how to overcome difficult scenarios during surgery. Again, it's not moving. Rest. Types of laparoscopic hysterectomy, the total laparoscopic hysterectomy and laparoscopic hysterectomy, supracervical, laparoscopic assisted vaginal robotic, and the V-nodes hysterectomy. Of course, when we say total, it means we perform the laparoscopic hysterectomy from A to Z by laparoscope. Even suturing of the vagina also has to be by laparoscopy. If we do the suturing of the vagina through the vagina, then it is a laparoscopic hysterectomy and not total. If any more steps will be done through the vagina, it will be a laparoscopic assisted vaginal hysterectomy. The supracervical is leaving the cervix behind. Robotic is by using the robot technique. The V-nodes hysterectomy is a very recent technique that is performing the hysterectomy all through the vagina, but by minimal invasive technique. Simply, the vagina, the cervix has to be incised all around, and then anterior and posterior colpotomy has to be done, and then clamping and ligating the uterosacral ligament. Then we insert the V-nodes device, and I will just show you the V-nodes device. This is the device where you insert it through the vagina and then insufflate the abdominal cavity, introduce the instruments and the camera, and do whatever pelvic surgery you want, whether hysterectomy or you can deal even with the adnexal surgery. The difference here is that the surgeon will work from caudal to cranial, but in laparoscopy it is from cranial to caudal. And we will talk more about this technique in a later presentation in this session. Okay. Rate of laparoscopic hysterectomy. In the United States, a study in 2003, only about 11% of the hysterectomies were performed laparoscopically. By 2010, this number had increased only to 20 to 30%. Despite consensus statements by both the AAGL and the ACOG stating that minimally invasive hysterectomy should be the standard of care, more than 50% of hysterectomies for benign indications are still open procedures. By 2012, in a single academic community hospital, 93% of the hysterectomies were done by the laparoscopic route. So as you see, if we do a national study, the rate of laparoscopic hysterectomy will not exceed 30 to 40% in most of the nations. But if we target a certain institution specialized more in minimal invasive surgery, then the rate will be 90% or even more. In France, in a multi-center cross-sectional study, including 23 French university hospitals that was long back in 1999, the rates of laparoscopic, vaginal, and laparotomic hysterectomy were 9.6%, 47%, and 43.4% respectively. Then 5 years... 5 years later, in France, in a study conducted in 12 French university hospitals, total laparoscopic hysterectomy was performed in 19.1%, laparoscopic assisted vaginal hysterectomy in 8.2%, total abdominal hysterectomy in 24.4%, and vaginal hysterectomy in 48.3%. So as you see here, the rate of abdominal route has decreased from 43.4% to 24.4% over 5 years. In the UK, total laparoscopic hysterectomy versus total abdominal hysterectomy in the treatment of benign gynecological disease retrospective review over 5 years that was published in 2016, we see a gradual increase in the laparoscopic route and a gradual decrease in the abdominal route. Now, if we target referral centers, as in France, such in Clermont-Ferrand, also in Strasbourg, and many specialized centers, usually you will find the rate of laparoscopic hysterectomy more than 90%. In Salam Specialist Hospital, where I do my surgeries, over the last 2 years, we had a laparoscopic rate of 60%, abdominal 34%, and vaginal 6%. And if we target the individual surgeons specialized in minimal invasive technique, like surgeons of Clermont-Ferrand, they have more than 90% rate. My own rate in the last 2 years was 96%. What are the challenges? Oversized uterus or big uterus, adhesions, obesity, ureteric injuries, morcellation techniques, and endometriosis, oncology, and difficult uterine manipulation. Before we talk about those challenges, I would just I would like to talk a little bit about the pelvic anatomy. In order to perform our surgery safely, either be by the laparotomy, by the abdominal route, or by the laparoscopy route or minimal invasive route, we need to know more about the pelvic anatomy and about the pelvic spaces. You know, by laparoscopy, everyone knows that we see better, and if we see better, we can understand the pelvis better, and if we understand better, then we can serve our patients better. So knowing those spaces are really very, very, very important to overcome a lot of complications and morbidities. Those spaces are divided into lateral spaces and central spaces. The lateral spaces are the paravesical and pararectal, Okabayashi and the Yabuki spaces. Central spaces are the prevesical, uterovesical, rectovaginal, retrorectal, or presacral. As you see here in this image, the paravesical space lies between the side pelvic wall laterally, where the external iliac vessels and the obturator internus muscle, and medially the urinary bladder, and the posterior border is the uterine artery and the parametrium. The obliterated umbilical artery runs through this space, dividing the space into the lateral paravesical and medial paravesical. The pararectal space, this space also has a lateral part and medial part, and divided by the ureter. It is a little bit caudally and posterior to the paravesical space, and the lateral pararectal space lies between the ureter medially and the internal iliac artery laterally, and the uterine with the cardinal ligament in the anterior border. Those spaces are really important in case you want to do a lymphadenectomy in cancer surgeries, and also whenever you have a difficult surgery with adhesions that you need to target your ureter and do ureterolysis safely. The lateral pararectal space is also called the Latsko space, and the medial pararectal space is the space called Okabayashi space. The Okabayashi and Yabuki spaces are actually not true spaces; they are false spaces. That is should be created during the surgery according to the indication. Can you please pass to the next? Okay, let me do it from myself. Okay, can you start this video, please? So I'll just share this video with you just to see how to enter the paravesical and the pararectal spaces. Here, it is the easiest way is to coagulate the round ligament, cut it, and then open the anterior and posterior layer of the broad ligaments. Posterior layer of the broad ligament, when it is opened and widened up to the pelvic inlet, parallel to the IP, you will access more deeply into the pelvis. Can you just, please, can you skip? Why it is slow? Okay, run it. Can you run it? No, can you run it a little bit to the end? Because the time will be running, you know. And I cannot control it from here, right? So I think that my target was to reach down to the vital structures where you can see both the paravesical and the pararectal spaces divided by the uterine artery in this video. But if you can see, maybe it's not clear in this video, maybe it's better here, that if you see those bubbles are usually created by the gas in the laparoscope. It indicates that there is avascular space behind them. So you can safely go in with your instruments and dissect more deeply. Here, if we go more, I hope that we could run it more, but I think it's not possible. So you can see the ureter here down. This cannot work as a pointer. Where? This one? This one? Okay, this red one, right? Okay. I think you have started from the start. Yeah, repeated. Okay then, no problem. Okay, let us talk about the Okabayashi and the Yabuki spaces. So these spaces located, as I said, in the pelvis, a little bit medial to the lateral spaces. The medial pararectal space, as if we want or need to open the Okabayashi space, we need to open the peritoneum lying on the ureter, push the ureter laterally and the peritoneum medially parallel to the rectosigmoid, and there you will find down the inferior hypogastric nerve. It is an important space in case we need to know to perform nerve sparing surgery. The Yabuki space is the space lying between the vagina medially and the ureter laterally, and also in this space we are targeting to preserve the innervation of the bladder. So also it is important in surgeries where you need to do the radical hysterectomy for cancer surgery. The central spaces, the prevesical space, utero-vesical, rectovaginal, and retrorectal or presacral. Those are the central spaces that is important to dissect in most cases in prolapse surgeries and also in endometriosis surgeries. We go back to the challenges. I will start first with the oversized uterus or the large uterus. When we say oversized uterus, it means that the uterus is about 12 to 14 weeks pregnancy size, or the uterus weighs more than 300 grams. So what are the limitations? Limited exploration, limited lateral vascular access, limited uterine manipulation, and difficulty in removing the uterus at the end of the surgery. So whenever we have a patient with a large uterus that is in need for hysterectomy, and we know from the workup and the biopsies that we are dealing most likely with a benign pathology, it is helpful to give the GnRH analogs 3 to 4 doses to reduce the volume of the uterus and make the laparoscopic surgery more feasible. And if we have a large uterus obstructing the umbilical area, we can go up with our insufflation by using the Palmer's point or even by the open Hasson technique, and also using the VisiPort will help in these cases. Put your trocars higher up in the upper abdomen to control your surgery better. The morcellation techniques, we'll talk about them in a later slide. If you have a big uterus also, which is always, big uterus means always fibroid. Most of the cases, the indication will be because of a fibroid uterus. So you can do, in certain cases, a myomectomy to ease the remaining steps of the surgery and the hysterectomy. If you have a broad uterus that is obstructing the upper part of the pelvis and there is no windows in the cavity, then you can do a supracervical hysterectomy and then target the vascular pedicles to do the tracheolectomy and to finish your surgery. Always avoid bleeding at the start of the surgery, because if you have a bleeding at the start of your surgery, then the risk of conversion to laparotomy will be higher. So if it is accessible, to ligate the uterine arteries at their origin, you can do this, or inject vasopressin. The next slide, I'll show you. Can we run this video, please? The left side, the other one. Stop here. Okay, go to the other side. You can see this uterus. This is one of my surgeries. Actually, the other video is not very clear. Here you put the uterus is reaching up to the umbilicus, so there is no view at all if you go on through the umbilicus to control your surgery. But putting the camera at the upper abdomen at the level of the falciform ligament, then you can see that the ureter is much smaller, and you can ease and control the surgery in a better way with less risk of morbidity. Since we cannot run, please, we will go to the next slide. Okay. Start from the left video, please. Yes, this one. This is another surgery. This is also my case. This uterus is enlarged with a fibroid. This fibroid is obstructing the left side of the pelvis. So if you see after removing all the bowels out from the pelvis, this is the fibroid there obstructing the left side of the pelvis, and this is the uterus here. We didn't have any problems with the adnexa, but the problem was in controlling the left uterine vessels here in the left side. So all this, we should run it actually because this is a waste of time. I just want to show you when we antibate the uterus, how the pelvis will look like, but you know, because of the time, can we run both of them simultaneously? Can we do this? Yeah. So if you see here, I will keep them running both together so that it will be easier. This is the same surgery. Here you see the fibroid is obstructing the left uterine vessels. So it was not really feasible to skeletonize the vessel. And if we start cutting here, there will be bleeding, and maybe with a lot of coagulation, we will have the risk of urethric injury and thermal spread to the adjacent tissues. So at this point, we've decided to do a myomectomy. I'll show you how different the view was. Okay, run both of them together. So this is the same surgery, okay? So we've done the myomectomy here, and then we proceeded with the surgery. See now the uterus after removing the myoma, how feasible it is and easier to do the hysterectomy with less risk of injury. And if we wait a little bit, like we would push the uterus to the other side, see, it is easier now to control the left side. So it is not, we can follow the steps of laparoscopic hysterectomy as it is mentioned in the SB guidelines, but it is always good to manipulate according to the need of each patient. So do a myomectomy if it is needed, do a supracervical hysterectomy, and then continue your surgery and do the total hysterectomy. Okay, adhesions and deep infiltrating endometriosis. The challenges here is the unsafe entry, organ injury, frozen pelvis and distorted anatomy, limited uterine mobility. If you have adhesions, you're suspecting adhesions, the patient has previous history of laparotomies or previous endometriosis surgery, or you examine the patient and you see a lot of tetherings, and the MRI also shows a lot of enhancements. So it is always advised to go away during your installation. So go away, use the upper abdomen for the insufflation by Palmer's point, by Lee-Honge point in the midline, or even by the open Hasson technique. So the dissection, if it is blunt, do for the filmy adhesions, but whenever you have dense adhesions, you need to use the sharp instruments like small snips with your scissor. Electrosurgery, always avoid monopolar, especially near the vital organs. The bipolar is preferable, and if you have the ultrasonic devices, it is also preferred for these difficult types of surgeries. And always remember that the bipolar device will dehydrate but will approximate the tissues, but the ultrasonic device will dehydrate but will not approximate the tissue. So if it is available, you have to use it better. And the retroperitoneal spaces, very important to allow you to navigate safely in the pelvis. And if you have a certain area of adhesions, you can also utilize the idea of organ suspension. If you have posterior compartment adhesions, you can suspend the ovaries to the abdominal wall or to the round ligaments. You can do hitching of the uterus to the abdominal wall. wall. There are a lot of techniques. I'll show you the next slide. We can run this one also. This is a posterior compartment adhesions where you have to find your way from the clean cleavage line from outside the pelvis, target the physiological attachment of the sigmoid colon, and then open. If you open medial to this white line, you will stay intraperitoneal. But if you open lateral to the white line, then you will be extraperitoneal. So it is all depending on you and the indication of the surgery as well, if you need to stay intraperitoneal or extraperitoneal. Then once you're done with and you're entering the space, find your vital organs, do the ureterolysis. Then when you reach to the adhesion area, you know now that you are safe, the ureter is away, the great vessels are away, then you can start doing the adhesiolysis safely. Obesity. Morbid obesity now, it is not a contraindication to laparoscopy in most of the cases. So it is all about maintaining the ventilation of the patient throughout the surgery with some tips and tricks between you and the anesthetist. You can perform the surgery safely to the patient. So the challenges are anesthesia and ventilation, positioning of the patient, nerve injury, thromboembolism, entry, umbilical position, and visualization. So if you have a morbid obese patient and she is indicated for hysterectomy, always use the bariatric beds. The bariatric beds are wide and can go lower down more than the standard theater beds. And use the foam sheet to prevent the patient from slipping during the surgery. And then when you do the anesthetization, of course, it is always recommended to do the anesthetization while the patient in the flat position. So use the Palmer's point and the Hasson technique. It is proved to be safer than entering with the traditional technique. But of course, it depends also according to the expertise of any surgeon. The usual way you want to enter and you know that it is safe and you are practiced to perform it, you can do it. Then once you are done with the anesthetization, with the proper size of the trocars and the proper length of the Palmer's needle, which is at least you need to the 150 mm, then put the patient head in a Trendelenburg position. Take all the bowels out. If you take the bowels out, then put again the patient head in the anti-Trendelenburg position until the bowels are resting at the level of the promontorium. So if you still cannot achieve a proper ventilation, then you can do the organ suspension, suspend the colon outside the pelvis to the abdominal wall, and then you can perform your surgery safely. The thromboembolic prophylaxis, of course, it is important, but it is also important in all laparoscopic surgeries in gynecology lasting more than 1 hour, even if the patient is non-obese. The ureter. We all know that the risk of the ureteric injury is a little bit higher in laparoscopy more than the abdominal route, but now it is comparable with the more experience in performing laparoscopic surgeries. The ureteric risk now is ranging between 0.3 to 1.8%. The common sites for ureteric injury during laparoscopic hysterectomy is at the ligation of the ovarian vessels, ligation of the uterine vessels, and at the closure of the vaginal cuff. What to do? What are the tips? You need always to keep the ureter under your eyes. So if you can see it intraperitoneally, then you don't need to open the spaces. If you have a difficult hysterectomy with adhesions, with endometriosis, then it is always advised to open the spaces and to see the ureter. Keep the ureter always under your eyes during the surgery. The manipulators proven that it has a great impact in reducing the risk of morbidities and ureteric injuries during hysterectomy because it is pushing the uterus away from the ureter. At the level of the IP ligament, it is always, if feasible, and advised to open the window in the posterior layer of the broad ligament. Opening this window and widening it will push the ureter away, and this will isolate the IP, and then you can coagulate and cut the ligament. At the level of the uterine pedicle, skeletonization. It is very important. Skeletonize well, remove all the surrounding tissues around the uterine pedicle, and this will reduce the thermal spread and also will prevent the excessive bleeding during surgery. Pushing the bladder away also will push the ureters away. Stenting. A lot of studies have proven that stenting the ureter routinely will not protect the ureter from injury. So if you want to stent, even in frozen pelvis and in difficult cases, it is not a routine advice to stent because you should not depend on the stent to show you the ureter. You need to see the ureter by yourself and to look into the anatomy of the ureter. So it is advised to stent the ureter in two scenarios. You have to decide stenting the ureter before the surgery if there is an abnormality in the urinary tract, like if you have a hydronephrosis or a hydroureter. If there is a pathology, you have to stent the ureter. During the surgery also...
You will have 3 minutes to finish your presentation.
Okay. During the surgery, you need to stent your ureter. If you have a lot of dissection and around the ureter and you think that you have compromised the blood supply of the ureter, stent the ureter to minimize the risk of post-operative fistula formation. So this, I would like just to run the slides. I will not show you the videos. This is for creating the window. These are all surgeries we've done in As-Salam Hospital, but I will just run them. Okay, morcellation and tissue extraction. The challenges are the disseminated fibromatosis and cancer spread. We all know the 2014 when there was a call from the FDA to discourage the use of power morcellator due to the incidental diagnosis of leiomyosarcoma and a specimen of laparoscopic myomectomy. And after that, there was a lot of trials to create new techniques to ease the tissue extraction safely, like the in-bag containment morcellation, the manual rocking technique and the C-incision technique, vaginal morcellation and colpotomy. So again, in 2020, there was another call by the FDA that permits the use of power morcellation, but only in a containment morcellation bags and also with the patient consented. Here are some of the endo bags or the containment bags that is available in the market. I used usually the one on the right, but all of them has the same purpose and the same quality. This is the rocking technique or the C-incision technique. Can you run this video, please? The rocking technique, simply, it is by putting the uterus at the end of the surgery in a normal endo bag, and then you bring the mouth of the endo bag through the umbilical port, and then put the wound protector and hold the uterus with one hand, and then put the knife and create a C-incision, and then rock the tissue, and then C-incision, and then rock the tissue until the whole specimen is outside. So in this way, it is very feasible technique that I found it very practical, especially if the uterus doesn't fit, if it is very large and doesn't fit the containment bag, or sometimes when I face a hysterectomy with a patient who has a small abdomen that doesn't fit the manipulation with the Limas bag. Okay. The cancer cases, we have a lot of challenges in cancer cases. Of course, all the cancer societies have recommended the use of laparoscopic approach in early endometrial cancer and in early ovarian cancer. But after the LAC study in 2018, there was a recommendation to perform all cervical cancer cases by the abdominal route. And this is because of the worse 5-year survival outcome in cases of in cases done by the laparoscopic route. So it is thought because mainly of two factors, either the use of the uterine manipulator from down, which may cause tumor fragmentation and dissemination, or maybe because of opening of the vaginal vault and exposing the cervical tumor to the intraperitoneal cavity. So now there are trials and studies to perform the laparoscopic approach in cervical cancer cases, but without the use of manipulator, and by also clamping the vagina below the level margin of the tumor, either by the use of the endo-GIA or endoloop, to aim to isolate the cervical tumor from the intraperitoneal cavity. So until we have the favorable results in the prognosis, we currently have to do all our cervical cancer cases by the abdominal route. In cancer cases also, you need to work always in a low CO2 pressure, aiming between 8 to 10 millimeter mercury. And this is proven to decrease the risk of dissemination, avoid changing trocars and replacing instruments, sealing the fallopian tubes, also in cases of endometrial cancer, and tissue extraction, always in a block and without fragmentation. And the next is the last slide, and already I've talked about it in the previous slides. Thank you very much for listening, and I really appreciate your attention.
Thank you very much for your nice, informative presentation, Dr. Sina. So if there is any question.
Cases where multiple fibroids are there. I usually counsel my patients if this is a difficult case and it is straightforward, benign these fibroids. There is a possibility that the cervix will be left, of course, with a negative pap smear. Okay, this will decrease the time of the surgery and decrease the amount of bleeding, the amount of difficulty, and will put the patient, you know, in view of her difficult case of fibroids, that she might end up having her cervix left. Maybe this is also another approach of having laparoscopic hysterectomy for a patient.
Yes, for supracervical approach, you mean? Yeah. So whenever you have multiple fibroids and you need also to ease the recovery of the patient. I remember that when we do a supracervical hysterectomy, I go next day in the morning, I enter, the patient is eating a large amount of meal, and you know, so yeah, it is feasible, but of course you need to do your workup, your biopsies, and you know that at least there is no risk of malignancy. I had actually one case only in the last 5 years, which was atypical fibroid symplastic type after a laparoscopic myomectomy. And because it was a laparoscopic approach, so it was easy to go on and to perform the surgery a week later with the definite resection for her. So if you do even if you leave the cervix behind, it is always feasible to go back and to take the patient back to the theater very soon, a week or two.
Thank you.
Any further questions? Yes, please. You mean? You mean if you do your workup before the surgery, if you have a benign pre-op biopsy and you perform the surgery on a large uterus, and of course you will do the containment techniques, then what happens if there is an incidental findings of, it is the same way when you do also, when you discover the leiomyosarcoma incidentally. This actually, when I was reading about this, I did not have any case until now that comes positive for malignancy after manual morcellation, not motor even, which comes as positive malignancy after that. But when I read about it, the pathologist here, it has to be a very professional in reading those cases, because there will be always difficulties in studying all the blocks of the specimen and to see the degree of invasion. And it is always advised to give the pathologist the MRI done before surgery. I usually never do a total hysterectomy for fibroid uterus oversized without an MRI before surgery. Yes, doctor.
If we have a difficulty, we have to go for subtotal hysterectomy. And still you have the options also. If you are doing subtotal hysterectomy with the laparoscopy, you can go for conization in addition to subtotal hysterectomy laparoscopy. It is
I did not get your question, please.
No,
you're commenting on her, because conization is a different indication than supracervical hysterectomy, right?
No, I just commenting about this question.
I have also one comment regarding the patients who have fibroids, which came leiomyosarcoma. I encountered one patient which been operated by laparoscopy, myomectomy, and when I saw her in the theater, we rely on the MRI, but you know that the MRI is not very specific and it is not diagnostic. And sometimes the radiologists, they just want to protect themselves and they put differential diagnosis, which is maybe not related, like degenerated fibroid, query leiomyosarcoma, query I don't know. And when we opened the patient, and unfortunately it was disseminated and it changed her staging because of laparoscopic myomectomy. So I don't know how it is reliable now to use. Is it with the bag? The risk is much less, or still there is a chance of disseminating the tumor?
With endo bag, with containment bag, most of the trials have been done now is to look into the feasibility of this bag. You are talking about a call from the FDA that was only in 2020. So all the containment bag have proven that the risk of dissemination is very, very minimal if it is there. And to go back also to the incidence of leiomyosarcoma, which is counted in 1 in 500, and in some studies 1 in 700. So it is extremely rare and low.
Yeah.
So until we get enough sample numbers, we can still consent the patient. That is why the recommendation from the FDA in 2020 says that you need to consent the patient and to give her the risk either to do it with the containment bag or without the containment bag. But of course, if we do the workup and we do the MRI, we can see the disseminated tumors, and for such cases, the approach will be very, very much against the minimal invasive technique. It is most likely, an atypical fibroid or a leiomyosarcoma. If you have already dissemination, like in this case.
I don't know, because according to the report of the doctor, she said it is a normal fibroid and she removed it. But unfortunately, when I opened it, I saw it was disseminated.
Yes.
And I went through the previous MRI, and it is just putting 5 or 6 differential diagnoses, means they were not even accurate. This is the problem. The problem, sometimes you will be in dilemma,
Yes. Always choose, Dr. Fadila, always choose the radiologist who will read for you, and always choose the pathologist who will see the specimen after your surgery,
Exactly, but in the private, it is difficult. Sometimes you advise the patient to go for even good doctors, they will not go. They will ask their friends, you have to go to this radiologist, they are good, you do it. No, they are expensive, we cannot afford it. This is another problem we face it usually in private practice.
Yes.
Yeah.
Do I agree?
Any other question? Thank you again, Dr. Sina, for a very nice presentation. We will go to the third speaker, Dr. Mohammed Sami. I think being presented by Dr. He is well known, Professor Mohammed Sami. He worked in KHUH and he have a previous long experience in other hospitals like in Germany and Egypt, and he's a professor in the RCSI as well.
So good afternoon, everyone. I'll be presenting the presentation supervised by Professor Mahmoud Sami. So first of all, I would like to thank the organizing committee for inviting me for the presentation, and also thanks for Prof. Mahmoud for giving me the opportunity to present our research in this conference. So simply our presentation will be a research that we conducted in King Hamad University Hospital along with Bahrain Oncology Center. It's about the prevalence of positive family history of malignancy among patients with gyne-oncology diseases or gyne-oncology cancers in Bahrain, a retrospective cross-sectional study. So to start with, our research has been published in February 2022, and these are all the researchers. I would like to thank all of them. It's a bit big number of people, but a great thanks for all your efforts. So my presentation will be about, first of all, a background from the literature, followed by the methodology, the result and discussion, and the conclusion. So to start with, just very brief information, brief points about the literatures, about what has been in the literature about the family history. So family history is one of the most important risk factors that has been identified in each gynecological cancer. And it's important to know that the knowledge of family history of cancer and its relation to the established mediating factors on women's cancer screening behaviors has been gained attention with the mixed findings related to family history of cancer as a motivator for women's cancer health protective behaviors. What I mean is the screening programs. So there are different studies internationally has been conducted in this area to figure out the exact relationship between the family history and the development of gynecological cancer. And some of these studies already have been found a significant relationship between the family history and the development of cancer in a way that the family history will be presented in a genetic predisposition or inherited mutations, or in a different or indirect way. What I mean is that the families will share the predisposing factors, including environmental, lifestyle, and the risk factors. So accordingly, they will present, or they will be at a higher risk of presenting the gynecological cancer. So coming to the main important information, that the most common types, or three main types of gynecological cancers are the cervical, endometrial, and ovarian. So just a quick statistic from the literature about these cancers, starting with cervical. Cervical cancer is the fourth most common gynecological cancer in female, and it is the seventh most overall. And according to 2020 statistics, there are around 600,000 new cases in US of cervical cancer. But regarding the cervical cancer compared to other cancers, it is less known about the role of the role of family history of this to influence the cervical screening program. So family history not playing an important role in cervical cancer in the screening program, I mean. For the ovarian cancer, and sometimes it is called silent killer. It's the eighth most common cancer according to 2020 statistics. And there are around 300,000 new cases of ovarian cancer in 2020. Now, the risk of ovarian cancer is observed to be increased in women with a family history of a breast, endometrial, or ovarian cancer as a first-degree relative. For ovarian cancer specifically, there are three main hereditary syndromes associated with ovarian cancer: breast ovarian cancer syndrome, which is most commonly caused by a mutation of the oncosuppressor genes, BRCA1 and 2, and hereditary non-polyposis colorectal cancer, Lynch 2 syndrome, which is ovarian cancer along with non-polyposis colorectal cancer or endometrial or both of them. And the last syndrome is the last main syndrome is the site-specific ovarian cancer syndrome. So it has been known already from the literature that ovarian cancer has been linked strongly with the family history due to the inherited pattern of or mutations. For the endometrial cancer is the sixth most common cancer according to 2020 statistics. And again, in 2020, there are around 400,000 new cases of endometrial cancer. And for endometrial cancer, also family history plays an important role. So there is a convincing evidence that family history of endometrial cancer is associated with the increased risk of endometrial cancer. And the family history of colorectal cancer, Lynch syndrome, is also associated with the increased risk of endometrial cancer. So also the incidence of endometrial cancer is increasing with a lifetime risk of around 3%. And this risk is higher with individuals who had endometrial cancer and the first or second degree relative. Now, why we are mentioning these statistics? Because gynecological cancer is mostly preventable with effective screening and lifestyle changes. So accordingly, there are many findings as well whether there is a relationship between the family history of malignancy and cancer screening behavior. So identifying patients with known risk factors, including one of them, which is the most important, family history, will possibly reduce the mortality and morbidity associated with gynecological cancer. So the aim of our study that to determine whether there is a relationship between the prevalence of gynecological cancer and the presence of family history, our own numbers and statistics here in Bahrain. And it is considered the first study in Bahrain to explore this area. So establishing the prevalence of positive family history in patients with gynecological cancer will help in guiding the screening and facilitate early detection and hopefully will reduce the rate of progression of the cancer. So I'll be starting by our methodology in our research. So our research is a retrospective cross-sectional study done in King Hamad Hospital along with Bahrain Oncology Center from 2016 to 2020. We included in our research all gynecological cancer which has been following in these two centers during these 5 years. And the gynecological cancer that we evaluated are vulvar, vaginal, cervical, endometrial, and ovarian cancer. So regarding the statistical analysis, it was performed with a GraphPad Prism. Data was tabulated and represented by percentages, and Fisher's exact test was used to determine the relationship between the prevalence of the various types of gynecological cancer and the presence of family history in those patients. And p-value of 0.005 was used as a significance value in our results. So briefly, in our results, I'll be presenting some graphs along with the details. So to start with, this our simplified about the prevalence simplified graph, as you can see here. So we found in these two centers that endometrial cancer represent the most, it is the most prevalent type of Bahrain with a percentage of almost 50% of the cases, followed by ovarian cancer with 29% of the cases, followed by 14% of the cases were cervical cancer, and the rest with the vulvar, vaginal, and fallopian. This table, I hope it will be clear. Can I use a pointer here? From here? No. Okay, so this table is summarizing that with each year, what are the prevalence of gynecological cancer. As you can see, first of all, our total sample size was 216 cases. And we found 2019 had the highest prevalence of gynae-oncology cancers with a percentage of 36.6, 79 cases. And again, as it is being shown here, that uterine cancer represents 50% of the cases, followed by ovarian, then cervical. So this table also showing the prevalence of positive family history of malignancy with the family history of other gynecological cancers. Specifically, we studied breast, ovarian, and uterine cancer. So we had almost around 34% of the cases, which represent around 24% of the cases had a positive family history of breast, ovarian, or uterine. And interestingly, also we had found that breast cancer is representing the positive family history of a breast cancer has been found in 59% of the cases. So it's quite important, the presence of breast cancer in the family history as a predictor for uterine or ovarian cancer. Also, as you can see in this table, we had that breast cancer represents 44% of the family history in endometrial cases. And interestingly, compared to the endometrial cancer, which is represent 23%, which is less than that in uterine cancer. This table also studying a different part, which is the prevalence of positive family history depending on the degree of relative, first, second degree, and third degree. And obviously, as you can see, we found the first degree relative will represent positive family history in first degree relative represents 71% of the cases. So again, our total sample size is around 216. The most prevalent gynecological cancer was the endometrial with a percentage of 50%. And we found that there is 52 cases representing 24% had a positive family history of different type of cancers. And there are around 20 patients, or 9.3% had a positive family history of a breast cancer. So there are several factors have been linked to the predisposition of hereditary cancer. These factors include the presence of multiple cancers in the family, 2 or more primary cancers in one person, or cancer in early presentation. We noted that endometrial and ovarian cancer are the 2 types of gynecological cancer that has been associated with family history, and were the most prevalent types of gynecological cancers encountered in our institutions. So we found that statistically, and also we found there is no statistically significant result when comparing the risk of developing gynecological cancer of one or multiple types cancer in the same patient. So the number of cancer in the same patient, in the same family, is not statistically significant in predicting the family, the development of the cancer. Additionally, endometrial cancer and breast cancer also are known to share the similar risk factors, such as nulliparity and exposure to an unopposed estrogen. This explains the strong relationship with the family history of endometrial and breast cancer. The presence of 2 primary cancers, such as breast and endometrial cancer, in the same individuals implies the possible etiological association between the 2. So now, for breast and ovarian cancer, they are associated also with autosomal dominant cancer. As I already mentioned in the start, the inherited mutated genes like BRCA1 and BRCA2, I already mentioned at the beginning. We found that 20% of women with ovarian cancer had family history, and 62% of those had a family history of either breast or ovarian cancer. Our study did not dwell on association between the cancer syndromes in the families and the prevalence of gynecological cancer, as in this study specifically, we did not study or explore genetic testing, but actually we have another study which is focusing on the genetic testing and different genetic mutation, will be published soon, inshallah. we established that breast cancer was the most prevalent type when investigating in our patient family history. And also we found that the endometrial cancer is associated with positive family history on almost 1/3 of the patient. With regard to vulvar and vaginal and fallopian tube, we did not establish a relationship between them and the family history as expected with a low number. We had only 3 patients for all of them, so we could not figure out a real relationship because of the number. Our limitation in our study, the retrospective design of our study can explain some missing data because already we only depended on the patient records. So some patients, there are many missing information. So establishing a study with a larger scale might provide us with a deeper understanding of a possible relationship between the family history, especially family history of gynecological cancer and the risk of developing gynecological cancer. Thus will confirm our finding. So in conclusion, the family history is an important risk factor, especially in endometrial and ovarian cancer. Accordingly, determining the family history of malignancy will help in guiding the screening of gynecological cancer, thus attributing and helping in early detection and so better outcomes. So it's crucial to increase the public awareness of the possible risks of developing gynecological cancer. With regard to family history, primary care provider plays an important role in preventing and in the prevention by encouraging patients to undergo relevant screening and make it necessary changes in the lifestyles and when assessing them in the primary care, and that will help in early detection and so better outcomes. And these are my reference. I think I have missing a slide. So thank you for your attention. Any questions?
Thank you, Doctora, for the informative presentation. If any question from the floor, please. You have a question?
Thank you very much for the nice presentation, which is really we don't have in Bahrain a lot of study regarding the incidence of not only the cancer or even of other gynecological problem. I just want to highlight on one point because I read and even there is a big study in the state regarding the fallopian tube cancer and its relation to the ovarian cancer. I don't know if your study, you kept this in concentration or not.
Actually, we did not cover this area, and for fallopian tube itself, we put it separately. So studying the relation, you mean in the family history or just the relation which is in general?
The relation between fallopian tube cancer and ovarian cancer.
No, actually.
Because they mentioned that it is the ovarian cancer, it's mainly originated from the fallopian tube due to the changes which happening in the fallopian tube.
Actually, we have only maybe 2 cases. It is which has been diagnosed as fallopian tubes carcinoma, because that is in the most of the all societies and the guidelines, they are considering the ovarian and fallopian tubes. It is one type of malignancy. They are not separating each other. Even the peritoneal, that is, they are considering the 3, primary peritoneal carcinomatosis and so like this. It is very few to find it. We are missing a registration. Really, this is very good that we could find some data which we can publish or can present it. This is, we are missing it as a registration and the documentation for our patient, and it is a defect in our areas, really.
Yeah, because now even in Europe, they are advising to do a total hysterectomy with removing the tube and ovary, as they blame the tube. It could be the origin of the malignancy in patient with a high risk.
It is mandatory.
Yeah.
It's nobody removing the ovaries without removing the tubes. This is mandatory. It's okay. It is a source. It is a types of ovarian carcinoma.
Yeah, thank you.
Hysterectomy also, now this is the recommendation that even if you are preserving the ovaries, but you have to go for salpingectomy. So this is now the recommended practice now to go for hysterectomy with bilateral salpingectomy, irrespective of the ovaries.
Exactly.
Yes, because of this problem.
Thank you very much.
Next presentation. Yes, one more question. Inspector, تفضلي.
You can speak loudly.
You're too far.
The number is this.
Thank you for the excellent study which is being done in Bahrain. Actually, I'm family physician, and as you know, we as family physicians, we do the, the screening test for the woman in reproductive age, like pap smear. And as you said, ovarian cancer is the silent killer. So I think we should do screening for ovarian cancer. But you know our limitation in the primary health care. So what is your recommendation? To my knowledge, from my experience, I had come across many ladies with ovarian cancers. Yes, it is increasing. The prevalence of ovarian cancer, it is increasing. So we should do something for the ladies to screen them for ovarian cancer. And you know our limitation in the primary health care. So what is your recommendation? Thank you.
So, as I already mentioned, there is no screening program for ovarian cancer, but as I mentioned, identifying the risk factors and trying to identifying the high-risk groups might help in early detection or for the patient with ovarian cancer.
Oh, actually, I do agree with what your answer. It's okay. That's the first thing we are giving you. That is now the WHO and all the societies have announced that the cancer as a gene. Okay, it's a gene disease. So knowing at least one question regarding the family history of breast, ovarian, any other gynecological cancers or colon even, that is okay. It will lead you to give us spots on this patient and even to do what you need to do for her. That is okay. But just screen them by the family history, just by question.
Yeah, so in the primary healthcare, what we should do?
Ask her about the family history.
No, other than the history. I know this is very important.
No, for
the history is very important. So shall we do only pelvic ultrasound? Shall we do tumor markers, for example?
Okay. No, tumor markers you cannot do unless this is you are suspicious. But at least you have a bedside ultrasound if you feel that is okay. That again, if you find any lady, she has a family history of breast cancer, uterine cancers, ovarian cancers, that is do for her screen pelvic ultrasound and she can keep her on the eye and just raise her awareness that is the possibility she may develop the ovarian cancer. And this ovarian cancer, it is very difficult to be detected. Please just come every year and ask if you have any symptoms, early symptoms, you can come directly. It's okay. But again, it is different from the breast, it is different from the cervix, it is different from the uterus that you can screen. Cervix, it is you can do pap smear. The breast, you can do examinations or that is mammogram. But ovarian, it needs that is a thoroughly discussion with the patient regarding their family history, genetics, abnormalities, and all.
Okay, thank you.
We have also limitation not only in ovarian cancer here in all Islamic countries for the cervical and endometrial cancer screening also, because of in single patients, they reach, the middle age, even above 40 years old, and we see them having, abnormal findings with thickened endometrium, and still we have limitation to sample them, and even to do the pap smear test. It is very difficult. We face this limitation. What is your comment, doctor?
This actually, I'm saying that is nowadays we see that there is increased awareness about all ladies regarding the pap smears and regarding the endometrial biopsies or sampling. I'm using to catch the patient when she comes to the clinic for any other reasons. And I am used to ask her, when was the last pap smear? What do you know about the last pap smear? Actually, regarding the endometrial sampling, you don't do that is endometrial sampling unless you are suspecting something, thickening, or she's on tamoxifen. Just nowadays, this is have a large number of patients with breast cancer or taking estrogen and so. So endometrial sampling, it is just if you are suspecting. And pap smear, I am catching them. But I have to say that there is a raise awareness that now everyone is coming and saying, just ask them, and even if she's coming for vaginal discharging, ask them and encourage her to take from her a pap smear.
But in a private practice, the situation is very difficult because of the payment, you know. Many women, we advise them to do the pap smear and they said, okay, we will go to the health center and do it because it is done there free. But when we give them annual checkup and we ask her for the pap smear, she will not do it.
Yeah, no, half of them, they will follow your instruction because they know that you are caring about them. And the other half, they will say, this is, we are not pay, just advise them, please go and explain for her why you are asking to give this to the primary health without paying anything.
Yeah, and my point also is about the virginity. This is my, even if you will conduct studies, you know, it will be a factor of bias, the virginity. If the patient is virgin, you cannot really do.
Actually, we had advanced cervical cancer in 2 of the virgin patients. And this was the dilemma that they refused for any pelvic examination till the end, till they develop the complications and they end up in like advanced stage. And
I think it is in our culture.
In terms of the studies and a factor of bias.
In our culture, it is very difficult to ask the virgin one to do for pap smear failure. And it is not advised all over the world. That is, if she's not sexually active, and she's to do pap smear. But I think that's what is coming to solve these problems. It is a campaign that is now for massive immunizations. It has been started, that is the last month in Saudi Arabia. That is now between 9 and 11 years. We have to go for massive immunization of the girls between 9 and 11 years.
Thank you. Thank you, Doctor. Let us move to the next presentation. Our next presenter is Dr. Karl Jallad. Dr. Karl Jallad is a urogynecologist focusing on pelvic floor and urinary incontinence. He is internationally recognized for his pioneering work on natural orifice transluminal endoscopic surgery. He holds a double American board in obstetrics and gynecology from Georgetown University Hospital, DC, and in urogynecology from Cleveland Clinic. He is currently the acting chair of the Department of Obstetrics and Gynecology at the LAU Medical Center in Lebanon. And he will be talking today about the V-nodes hysterectomy.
I think he's online.
Online? Yes.
Hello, thank you for giving me the opportunity to present today. I will be talking about V-nodes, which is vaginal natural orifice transluminal endoscopic surgery. So, for those of you who don't know, vaginal natural orifice transluminal endoscopic surgery is the latest innovation in minimally invasive surgery. Initially, we used to do surgeries via a laparotomy or big incision. Then we transitioned to laparoscopy, as you can see in the second picture. And then the less surgery, which is single site surgery, was used. And now the latest innovation is to do surgery in gynecology via V-nodes, which means no incision on the abdomen. So it stands for natural orifice transluminal endoscopic surgery. And it's natural because the technique avoids making visible scars by using the natural orifices, like the mouth, the vagina, the anus, or urethra. In our case, it's the vagina. It's transluminal because it's an access that is directly through the abdominal wall, as it is in classical laparoscopic surgery. But it goes through the lumen of another organ, such as stomach, vagina, rectum, and all those things. And then it's endoscopic because we are using endoscopic surgery instruments when we're doing this type of surgery. So although this seems to be a new technique, actually the first publication I did was in 2016 when I was still in training in the US at Cleveland Clinic, when we performed the first natural orifice endoscopic salpingo-oophorectomy. So at the time, we were training on cadavers, and this is the first imaging of a cadaveric testing of the technique. Here we are going through the vagina. That's a port that's placed in the vagina. And we're looking at the ovaries and the bowel. Obviously, there's no blood flow, there's no blood supply, there's nothing moving because this is cadaveric work. And then after we had tested the technique, here you're seeing us testing the technique on a cadaver, we realized that it was actually a feasible technique to be used. And here you can see the completion of the oophorectomy. Now, the next case that was done was on a live patient. And in 2015, while we were operating and performing a vaginal hysterectomy, one of the ovaries was stuck and we absolutely needed to get it out because the patient was a BRCA positive patient and needed her ovary to come out. So what we did is use that technique to look for the ovary. And after identifying the ovary that was hidden behind the bowel, we successfully completed the first V-nodes salpingo-oophorectomy. And we published our data in the Green Journal. And since that time, we continued our work in developing this technique. And now this technique has spread throughout the world and gaining a lot of momentum in our part of the world. So as you can see, it's a very straightforward procedure and you have excellent visualization and you can even see the ureter in the background that's moving under your field. So there are several types of V-nodes. The first type of V-nodes is a pure versus hybrid. You can consider, for example, the V-nodes transvaginal nodes. It can be done as a hybrid or a pure, which means you're starting from the beginning with the V-nodes, or you're starting in a conventional way where you're doing your colpotomy, and then after you do your colpotomy, you place the port. So what kind of procedures can be done via V-nodes? In gynecology, currently, we have the hysterectomies and we have the adnexal surgeries as mainstream. I would say myomectomies, adhesiolysis, and other surgeries are for more advanced surgeons and not great options for people who are starting with this procedure. So the patient is placed in dorsal lithotomy position, and the access is the same access you would do for a vaginal hysterectomy and the same positioning. The potential benefit of that surgery is one, less pain. Second, less skin infection since there's no skin incision. Better cosmetic result because there's no incision. Less risk of post-op hernia, again, because there's no incision. Faster recovery because those patients are not feeling much pain. There's less OR time, less need to morcellate, and there's no need to perform a mini laparotomy to extract large specimen. At the time being, there are some exclusion like endometriosis, ovarian malignancy, pelvic radiation, pregnancy, patients who prefer to avoid vaginal access, history of severe PID, pelvic radiation, and a prior hysterectomy. Now, like everything else, with time, those will not be contraindication, but at the time, I would avoid doing those cases on such patients. So here is the technique of performing a V-nodes. It starts as a vaginal hysterectomy, where you are first grasping the cervix, and you can do this the way you prefer. In my case, I tend to inject lidocaine with epinephrine, as you can see here. And after injecting lidocaine with epinephrine, you perform your incision circumferentially. And here we're injecting still the lidocaine with epi in the posterior cul-de-sac. And as you can see, it is bulging and blanching. And then now we are going to perform the incision. And as you can see, that incision is done circumferentially. Some people prefer using the cautery, which is completely acceptable. And some people like to take more or less, that's also completely acceptable. So after you perform this colpotomy, you will move the anterior and posterior part of the vagina out of your field. You can continue dissecting with the knife, or you can move to the curved Mayo scissors. Here we are moving to the curved Mayo scissors, performing the dissection and starting to develop our planes. If you are in the right plane, this shouldn't be very difficult. Here we're moving the uterosacral ligaments and making more room. And then the next step will be the entry in the posterior cul-de-sac. Some people prefer entering anteriorly first, which is completely fine. The most important thing is to recognize whether or not you are properly in. And here we are in. You place a finger, make sure there's no adhesions. You start to sense the size of the uterus, and then you place a speculum. Now, the entry in the anterior peritoneum, that's the tricky part for some surgeons. So for those who are not used to doing this, they will find this task a bit difficult. But for those who are experienced vaginal surgeons, they will see that this is actually a straightforward approach. We're looking at the edge between the bladder and the peritoneum, and we're cutting and entering, and again, putting your finger to make sure that there are no adhesions and to make sure that you're not into the bladder. Now, you are going to suture the uterosacral ligaments, and those are important because for surgeons like me who do reconstructive surgery afterwards, this is important to tack the uterosacral and to go up and suspend the apex and perform. There you go. Here, the stitch has been placed. I hemi those stitches, meaning I double stitch them. Some surgeons don't, which is fine. And now, to this point here, this is a conventional approach for a vaginal hysterectomy where one could continue in the same direction or switch to the V-nodes part. So now we're shifting gears. This is the older V-nodes where it was purple in color. The new V-nodes is ruby in color, so reddish. You place those 3 ports in a triangular fashion around the port. And after placing those around the port, you will insert the retractor into the vaginal canal and then apply that port over that retractor. Then you will insufflate and you will gain access into the cavity. So here I'm going to be showing you a vaginal access V-nodes hysterectomy. This is actually my colleague, Jan Backlund, who's a famous V-node surgeon who's performing this surgery. So as you can see now, you're in, and this is through the vaginal access. You're clamping, coagulating, and cutting. This is the broad ligament. If you are in the right space, there shouldn't be much bleeding. And now you are close to the uteroovarian ligament. You're dissecting the broad and getting close to the uteroovarian. At this point, you don't continue your surgery. You stop and you go to the other side. And the reason why you do this is because if you cut this fully, then the specimen, which is the uterus, will flip on you and it will be harder to do the other side. So as you can see, that's the ovary. We are leaving a small piece that's tagged, and we have moved to the other side. The other side is a bit thicker, so you have more bleeding. And here we're clamping, coagulating, and cutting. Once again, clamping, coagulating, and cutting. You can see that this side is a bit bigger, and there's a fibroid at the top on the patient's right side. On your screen, it's on the left side. And again, this is back bleeding from the uterus, from the fibroid. Here you are clamping, coagulating, and cutting to the ovarian ligament. And here you can transect it completely and go back to the other side, cut it, and your surgery is over. As you can visualize, the iliacs in the background and the ureter is in the background, and you have an excellent view of what is happening. The decision in this case is to remove the tubes, which is kindly the recommendation to minimize the risk of ovarian cancer in the future. So now is a good time to do this while the uterus is still attached to the ovary. Now we have completed the right side, the patient's right side, and that was the last bite on the patient's right side. So we go back to the initial left side. As we can show you here, you are removing the tube again with this specimen, and the tube is still attached to the uterus. This way you will remove the whole tubes, uterus, and cervix as a single specimen. If the specimen is too wide or too large, then you have to bring it down to the opening and you morcellate. If the specimen is not too large, then it should be able to pass without any problem. Now, here I will be showing you another application of Vino's surgery. Here I'm operating and performing the hysterectomy part, and here the hysterectomy part has been completed. Now we are going to do a uterosacral ligament suspension, which is extremely important for patients with big prolapse. So we are grabbing the uterosacral ligament and placing our stitch. And for those of you who do those surgeries, they will notice that the ureter is actually 1 centimeter to 2 centimeters away. So it's not that far. And after placing 2 stitches on this side, you place 2 other stitches on the other side. This is extremely high in the pelvis. To give you an idea, this is approximately 11 to 12 centimeters inside the vaginal canal. So this is not your usual McCall suspension or the small suspension where at the end of the vaginal hysterectomy you're putting 1 or 2 stitches. This is much higher and also closer to the ureter. You have to avoid the rectum midline, and on the other side, the ureter. Those are the borders of your surgery. And once you've placed the first stitch, you can pull on that stitch and place a second stitch. And here you're seeing me putting the second stitch. So once this part is completed, we can attach those delayed absorbable sutures. In this case, we are using PDS, and we tag those sutures to the vagina, and they're very sturdy, and this will give you an excellent elevation of the vagina. So here I'm showing you the proximity with the ureter. It is close, but it's not kinking the ureter. You have to do a cystoscopy at the end of this case, because if you don't do a cystoscopy, you might kink and get in trouble afterwards. So this is a must if you're doing not the venous hysterectomy, but the venous suspension. Now we are tagging those sutures, and those are put on the cuff, and we're closing the cuff. And then once you tie those sutures, you will see the cuff go from the opening of the canal all the way up to the apex. And this will give you a vaginal length of approximately 9 to 10 centimeters. this patient will not have a recurrence prolapse in the apex. The apex will be up for a very, very long time. They could recur anteriorly. That's why you should also do an anterior repair at the same time. So I don't want to show you just easy cases. Here is a V-nodes hysterectomy of one of the first cases I was doing. And in this case, you can see it's a much bigger specimen. It's much bloodier. And in the initial part of the technique, we didn't know exactly how to put our port, whether we should go to the left, whether we should start to the right. We should use a 30-degree or a 0-degree. So here, it's a new assistant, new team, probably number 3 or 4 surgery that we were doing. And the reason why I'm showing this is because some of you might start doing V-nodes and will be discouraged after doing their first or second. And they'll say, it's very difficult, I'm not seeing well, and I'm not comfortable. So I show you this video to tell you that, like every surgery, when you start in the beginning, it is not going to be an easy surgery. After your 20 cases, so it takes 20 cases to start being comfortable, but it probably takes 50 cases to be much more comfortable, and 100 cases to really feel that now you have grasped this procedure, you have seen the complications, and more importantly, you know how to manage them and expect them. So you can see here, we're clamping, coagulating, still the same technique, but a bigger uterus and more bloody specimen. So the other application is to do an oophorectomy. And if you think that a vaginal nodes hysterectomy is a nice surgery, then wait till you see this footage. It is even much nicer to perform a oophorectomy. This is a case of a 65-year-old patient who had this tumor, and this was 5 centimeters. The markers were negative. We kept watching and monitoring, but at the end, she decided to have it removed. So we're removing it intact. This is through the vagina. A posterior colpotomy is performed, and that procedure takes no more than 8 to 12 minutes, because all you have to do is clamp, coagulate, and cut. And you would be surprised how easy it is to do a ovariectomy or adnexectomy, because that specimen is sitting and waiting for you in the cul-de-sac, and now you can put this in a bag. In our case, we didn't want to risk any risk of spillage and remove the specimen. Now, for those of you wondering, yes, you can do ovarian torsion through V-nodes, and yes, you can do ectopic surgery through V-nodes. Now, here are some tips. For those of you who are interested in V-nodes, you should carefully select your cases. You cannot start with advanced cases, difficult cases. The OR setup is new for everyone, so you have to come ahead of time and you have to do it yourself. You need a dedicated set of instruments, a vaginal endoscopy combined tray, otherwise you'll be opening 3-4 trays and it's going to be a nightmare. Always do a rectovaginal exam before the surgery to make sure that you can access the posterior colpotomy and perform your surgery. And remember, you don't need to get in anteriorly immediately. So you can delay the anterior access. And of course, like everything else in life, you should know your limitation and not get yourself into something bigger than what you can handle. The learning curve is like every procedure. I told you, you need to do first your 20 cases. And I would suggest you start with a hysterectomy and then try your adnexectomy. For a hysterectomy, pick something that you can safely complete vaginally, or you can safely complete via laparoscopic hysterectomy, and then you start testing the technique. Of course, you're not going to start doing those surgeries without going to the course and without getting your certification. And then at a later stage, you can tackle myomectomies or uterosacral suspension, so on and so forth. Some people say this is too new, there's no data. That's not true. So there are 2 big studies published on V-nodes, and those are randomized trials. The first is the HALON trial. It's a prospective RCT comparing hysterectomy via V-nodes and total laparoscopic hysterectomy. The intra-op complication was not significant. And the post-op complication, again, there was no difference. So in conclusion, the incidence of post-op complication with V nodes was low. The incidence of intra-op complication for V nodes was low. And as you would guess, the most frequent complication was a cystotomy because of trying to get in on a patient who's had prior surgery, like C-section. There was some limitation in the study. It was a single surgeon and it was only 1,000 cases. And there was also the effect of the developmental phase of the learning curve included in this study. There's another big study that you can check, and that's the notable trial. And this is adnexectomy by V nodes versus laparoscopy. And in this study, V nodes was noted to be non-inferior to laparoscopy for successful adnexectomy without conversion. But in addition to this, V nodes allowed shorter operating times and less post-op pain, but there was a trend to more adverse outcomes. So this is a pamphlet from one of the latest AAGL meetings in the US. For those of you who are not familiar with AAGL, it's the Society for Minimally Invasive Surgery in the US. And as you can see, people from around the world gathered to discuss this technique. And we did our first course with the help of Applied Medical in Lebanon on November 1st and November 2nd. And the second course was not too long ago in Dubai. And we're continuing to do those courses across the Middle East and the GCC area to develop and implement this approach in all parts of the region. So I thank you for listening. And if you have any questions, I look forward to having them. And otherwise, you can always email me and get in touch with me.
Thank you for the nice, interesting presentation. Actually, I have one question for you, Dr. Jallad. What is since you are a urogynecologist, what is the advantage of the V node over the vaginal hysterectomy, which I see in the video, it is more or less similar and it is less cost and the recovery, I think it will be the same.
Hi, how are you? Can you hear me?
Yes, we.
Excellent. So it's good to see all of you. I recognize a lot of faces. So at the present time, the application is for a big uterus and something you would do laparoscopically or open that you would convert to a vaginal case. And the advantage is not needing to morcellate before isolating the whole specimen. When it comes to the application in urogynecology, you are looking at the first 20 cases. So I've done 20 cases of uterosacral. Some colleagues in the neighboring countries have also done 20. So this is very fresh publications. It's still in infancy. We still do not know if there is any benefit or not of using the uterosacral via V nodes. Now, from the cases I've done, which are being published in the coming months, I can say that it cuts down on time by approximately 45 minutes. It also allows you to operate without two assistants and without extensive help. And it gives you better visualization to be able to place your sutures higher and also seeing where the ureter is to be able to perform this more appropriately. Now, whether or not this will be useful, we will have to wait for randomized trials, and we're in the process of working on trials with the US to be able to publish the data and see whether or not there's any efficiency. Just as a side note, sacrocolpopexy with mesh is doable via V nodes. I didn't talk about it because I think it's still controversial and I think it's still dangerous and the mesh erosion is still a bit on the higher side. But I have no doubt that in the future we will be able to get the proper technique to be able to do it safely.
Thank you for the nice presentation. Definitely, it's a new technique. I want to ask that because the ports were very close together, all the three ports. So there is limitation of movements while moving the hands and moving the instruments as compared to the laparoscopy, the normal laparoscopy we are doing.
Yeah, absolutely. So in terms of triangulation, Yeah, in terms of triangulation, this is easier than the single site surgery. There's an echo. Are you able to hear me?
We can hear you.
Very good. There is it's less difficult than the single site surgery. And the reason why is because the opening is wider. Now, compared to laparoscopy, the laparoscopy part of the V nodes is easier. It's very easy because you're just clamping, coagulating, and cutting. While in laparoscopy, there's much more movement and it's more dangerous because you're getting closer and closer to the danger zone, which is the ureter and the bladder. While here, the ureter is out and the bladder is out. So the difficult part in the V nodes is actually accessing anteriorly via the vaginal part. Once you're in, it's actually very, very easy because you're just working in a very simple space.
Hello. Can I? Okay. Thank you very much for your presentation. Actually, tell me what about the position of the patient when you are operating. How is the head? Is it steeply down? Because that is, you maybe interferes with difficulties of descending of the intestine and obstacles your view.
0 degree while performing the vaginal access, 20 degrees to 30 degrees when performing the laparoscopy part, which is 20 minutes, and then 10 degree when closing the vaginal cuff. So there is a bit of Trendelenburg, but much less than what you need when you're doing a laparoscopic hysterectomy.
I have one more question regarding the technique. What about if the patient have no descent and the cervix is flushing up? Is it feasible to do the V nodes or to go for the laparoscopic hysterectomy?
I think the surgeon should go with the route that they would feel more comfortable. Probably it will be the laparoscopic surgery because they wouldn't have done a lot of V nodes. Now, after 20 cases, they start getting used to it, but they will need 50 cases to really feel comfortable to do them. And the skill needed is actually the vaginal skill. If you are comfortable doing an anterior colpotomy on a cervix that has no descensus, then go ahead and try it. But I wouldn't do it on your first 40 cases. Now, where it has an advantage is once you're used to it, the patient ends up with 0 incision. And as big as the specimen is, it doesn't matter. You do not morcellate until you've isolated the whole specimen, and you can put it in a bag and then morcellate in a bag if you're worried about potential hyperplasia or potential problems with the fibroids that could cause leiomyosarcoma or cancer.
Thank you for your nice presentation. And we will move to the next lecture.
Thank you.
With Dr. Mahmoud Sami, he's going to present. This is the 3rd lecture or 4th? Very interesting, really. It's very, very nice studies you have done. Very good work.
Bismillah ar-Rahman ar-Rahim. Thank you for the audience to stay till now, and hopefully this presentation will wake you up, and we will play around the wheel which we have made, so it will give you a good understanding and good try. And thank you for Dr. Sami for the nice work and in publishing this guideline. Definitely it will add on our experience and our specialty. So I'm Dr. Gulmeen Raza. I'm just presenting this published guideline, which is development of the guide wheel for cervical cancer. Why we need to, it's not going. Sorry, here, this one. Okay, the colleagues which participated in this publication, and this is published in this year, February. So why we need to do this guideline? Because we know that the cervical cancer is really a very fatal cancer, and still there is a lot of morbidity and mortality which is associated with this cancer. And although a lot of progress has been made in diagnosis, prevention, and treatment of this disease, but still we see that the women are dying from it, especially in the low and middle resource income countries. And when we search at the global data, there is a wide disparity in the research work regarding this cancer. So when we view this study regarding the global and the public health aspects, so we need to strengthen the cervical cancer research so that more of the countries take part in this international activity. And basically, this is one of the preventable female malignancies that accounts for almost 300,000 cases. That's worldwide, and more than 500,000 women are diagnosed every year. And all these deaths are like 90% of related deaths are from the low and middle socio-income countries. So regarding promoting the research activity will definitely improve this problem. Regarding our wheel, so definitely this wheel is developed by comparing of the several guidelines, recommended guidelines, and the FIGO staging and what are the treatment modalities. So the guidelines which are compared are basically the National Comprehensive Cancer Network, the Society of Gynae-Oncology, the European Society of Gynae and Medical Oncology, American and British Society of Gynae-Oncology, and the International Federation of Gynae and Obstetrics. So as we mentioned earlier, this is the fourth most common cancer worldwide and the second most common cancer in the developing worlds. And we know the main modalities of treatment are the surgery, radiotherapy, and chemotherapy. And still the early stages are asymptomatic, and usually patient presents with the late and advanced stages with incurable disease. So detection of the pre-malignant conditions and treating them will definitely have a better outcome. So this wheel has been made based on the recommended guidelines and basically the National Comprehensive Cancer Network guidelines to help us, especially for the counseling and management and at each step of the cancer. So I will just talk about the wheel. So there are certain part of the wheel. It has a base, it has inner wheel, and it has on the back of the wheel basically, which shows how to use this wheel according to the staging, according to the FIGO staging. So the base of the wheel usually shows us the staging of the cervical cancer and the color-coded treatment modalities. And the inner wheel, which is placed on the base, it shows the treatment modalities and the available options of treatment. So this is how it looks like, the back of the wheel. I cannot enlarge it. No? Okay. Anyway, unfortunately, we cannot enlarge it. It looks a little bit jumbled up. But anyway, when you look at it, look on the online, it is very easy. It shows how to use the wheel. So it shows us the 13 different treatment modalities based on the cervical staging. And also it shows the stages of the cervix as well, according to the FIGO classification. So the primary treatment is, number one is usually the primary treatment. Another option for the primary treatment in which more clinical judgment is required. So the second step is usually for the surveillance, and then according to the wheel, the treatment modalities are described. So this how this wheel looks like when it is fully assembled with the outer part and the inner part, and also the surveillance has been mentioned. This is how the base of the wheel looks like, mentioning the stages of the cervix and with the treatment, color-coded treatment modalities. This is showing the inner wheel that is basically showing the treatment modalities and the available options for each. So there are 13 possible modalities of treatment and different options of treatment, which is mentioned on the inner wheel. So it shows the primary therapy, the surgical therapy, if additional workup is needed, the surgical findings of the specimen, the radiotherapy, chemotherapy, adjuvant therapy, systemic and therapy and surveillance, and surgical staging, and what could be the therapy for relapse, and palliative therapy, and observation, follow-up, and supportive care in some of the cases. So, the whole wheel will display the steps recommended to follow in chronological order to manage the patient under consideration. So as we mentioned that the first step will be the primary option for the therapy, and the second step is usually also for the primary therapy, but in that case, more clinical judgment is required and further follow-up is required. Second is the option for adjuvant therapy, and third is the option for adjuvant therapy and any further treatment. Fourth step is surveillance, and fifth step is usually reserved for the relapse or recurrence. So we have the different options. So we have like fertility sparing options in this wheel, which is mentioned from stage 1A1 to 1B1 and selected cases of 1B2 based on the con biopsy results. We have the non-fertility options for till stage A2, which is also based on the con biopsy results. We have primary therapy for 1B3 onwards till stage 4 based on the imaging or surgical staging. Then we have adjuvant therapy, which is also based on the surgical findings. We have primary therapy, which is based on the imaging results and depending on the presence of adenopathy or negative adenopathy. Then we have primary therapy, which is based on the surgical lymph node status, that whether they are positive or negative. Then we have incidental surgical findings of cervical cancer post-hysterectomy, and in case of stage 4B or distant mets. And then we have surveillance of or persistent or recurrent disease, and we have the therapy for relapse. So how this wheel looks like and how these different treatment modalities can be addressed by looking at the wheel. So the first option is for the fertility sparing option. So as you can see that the first as it's shown in as 1. So this is the primary option, which is basically 1A is the surgery. So you can do the surgery, and the second option is the second step for the fertility sparing surgery is the surveillance of the cancer. So this is how we are using the wheel and we are going through it. So all this is showing with the different stages of cervical cancer. The second sector is showing the, sorry. Yeah, the second sector is the option for the non-fertility options that we don't need the fertility. So these cases, as it's shown as the primary therapy, as it is shown as in red, as 1. So it could be surgery. So the next step is the adjuvant therapy, and the second step in this one is the surveillance. So as we are going through, we can see the different color-coded treatments and we can go through it according to the recommendations. So the third sector is basically for the stages 1B3 to stage 4. And as we can see that it could be it could be the primary therapy. So primary therapy could be in the form of radiotherapy, or it is observation, and then the next step is the surveillance. Then the next is the adjuvant therapy, which is based on the surgical findings. So we can see that the first option is the radiotherapy, and the second step in this case is the surveillance, or the first step, even we can, in case of like in certain cases, we can just do the observation, and we can just if like surgical findings are there, we can do in selected cases the observation only also. So there are different options for this adjuvant therapy. Then in the next sector, basically it is primary therapy, which is on the imaging results with positive adenopathy. So we have the option of primary therapy, then we have the radiotherapy, and the next step is the surveillance. Then another scenario is the primary therapy, which is based on the surgical lymph node status. So in case of surgical lymph node status, we have the primary therapy for the radiotherapy, and also different options of the radiotherapy. It could be external beam or intraoperative radiotherapy. So these are the options, and then surveillance. Then we have in cases where we have the incidental findings of cervical cancer post-hysterectomy. So we have the option that depending on the lymphovascular space involvement, and also depending on the risk factors. So if it's a negative lymphovascular space involvement, so we can do just the surveillance. But if there is positive involvement, then we can go for the further imaging and further surgery, as it is showing in the respected blocks. Those patients with stage 4B cancer with distant mets, that we can treat, and local treatment can be done. So we have the option of surgical therapy, and then the radiotherapy could be another primary option, and then adjuvant therapy and surveillance. So for persistent and recurrent disease, we have the, like, depending on where it is located. So we have the option of either radiotherapy or the surgical option in case, in selected cases. For the relapse with patients with the loco-regional or of cervical cancer with no prior radiotherapy, so the primary therapy is the radiotherapy. And then we have to further, and another option is just follow-up and care. So for the cervical staging, the good staging systems will definitely allow the patients with that we can just treat them across different centers with the same recommended treatment. We know that surgery is an option for early stage cervical cancer, and one option is conization in case of fertility sparing approach. Another option is hysterectomy, which could be radical, modified radical, or simple hysterectomy. For early stage cancer, we have fertility sparing option and good prognostic factors if no nodes are involved. And the patient has to be counseled on the treatment modalities, and alternative suitable options has to be discussed according to their individualized care cases. Treating the patients with cervical cancer usually involves with the advanced cancer usually involves the radiotherapy and the platinum-based chemotherapy. So basically, the aim of surveillance is to detect the recurrent disease early, where it could be managed early and effectively before it can become untreated. Okay. Follow-up is usually recommended every 3 to 4 months for the first 2 years, and then every 6 to 12 months for 3 more years, and then annually in cases of cervical cancer. Definitely prevention is better than cure. So just for all like this, the WHO has developed a very good the cervical cancer elimination modeling consortium, which involves actually 3 independent models. For human papilloma virus vaccination for the till the age of 15 years, and then effective screening of the precancerous conditions, and the treatment of the cancer. So this triple intervention strategy, which is adopted by the WHO, involves the use of vaccination programs, screening and treatment, so to eliminate the cervical cancer. And this is basically a very good strategy, which can prevent about a third of deaths from the cervical cancer in low and middle income countries in the next coming 10 years. And it can reduce 90% of deaths over the next century if we follow this model. And it has been implemented in the Latin America. This is the cervical cancer goals of 90, 70, 90, which means that 90% of the girls has to be vaccinated against HPV. 70% has to be screened between the ages of 35 and 45, and treating 90% of women, those diagnosed with the pre-invasive disease of cervical cancer. So this ECHO-ELA, it is an effective tool to enhance the collaboration and support countries that is the good progression towards the elimination of this cancer. Lancet has also published this year another their experience, and one of the association of the, because this is a common presentation in our practice, the women with the repeated recurrent urogenital infections and the association of cervical neoplasia. So they found that those patients with the, those who presented with recurrent infections, they have more association with HPV infection and more cervical neoplasia. So they also they also advise for the HPV vaccination programs and cervical screening, especially in women with these recurrent infections. But definitely we need more studies to find the cause relationship between these infections and pre-cancerous conditions. So that's all about this article. And if there is any questions. Unfortunately, we cannot enlarge the wheel, so I think not very very clear. But you can see it is a published article, so you can see it online.
Some of the attendants online, they were asking about the wheel.
They were asking about the wheel.
They want to know how to find it.
Sorry?
They want to know how to find the wheel, how to get it. Yeah.
Actually, you have to find it online. You can go through.
No, it's okay. It is actually, you can follow it online on the cancer research and science.
Yes.
But it is now in the phase of printing. It's okay, actually, if you can. Yeah. It is the cover of the wheel with all the information here. I inspired this idea from the pregnancy calculations, LMP, and so I didn't develop a new instruction. I developed only this how to fast find a decision and what we have to do. So the wheel is one outer wheel and one inner wheel. Okay, in fact, it is with all stages and how to use it. Just if we have any lesions, I have to find the lesions here and outer. And after that, I have to rotate the inner wheel according to the direction of the outer wheel, which lesions of I have. For example, this abnormal pap smear here, high-grade squamous intraepithelial lesions, and HPV not negative. Oh, I don't know. What I have to do quickly on my office, okay? I don't want to know to open the textbook or to open my laptop, but exactly I wanted to know exactly what I have to do, okay? So, for example, that's first option, second option, and third option. First, if you have HPV, high-grade squamous intraepithelial, here you find one. One, it is colposcopy. So you'll find it, you have to go for colposcopy. And 1A or 1B, it means that is you have, when you are doing the colposcopy, either to do directed biopsy or to do HPV coding out testing. Okay. After that, you find that it's the second step, that's to find everything is normal. It's okay. You have to repeat after which time. So it is so
very friendly to use it. I think for the residents, it is very good.
That is for everyone. Usually, I am not, remember every management scientifically, according to the guidelines, how to make it. So I have to go back and to try it and search for it. Okay, it is in your hand
how to use it step by step. 1, 2, 3, 4, 5.
So where we can find it?
You need to distribute it as a conference or congress gift to all the participants.
Yeah, that's okay. I do agree, but the Congress has to print it and I'll give it as a gift.
You can ask one of these medical, they agree there.
The sponsor.
Please.
Sponsors can.
Please, I developed and published 7 wheels this year for all the types, starting from the pap smear until the ovarian cancer.
How much is the cost?
No.
For us free.
No, I pay it for publication. I pay it for publication.
How much is it cost?
I asked actually if we are doing the 7 wheels for all that this is the types of cancer, it will cost around 1,500 BD for 200 for each one, in this form like this.
I think the medical representative, they are willing.
Are you ready?
They raise their hand.
You can discuss. He raised it now. He was ready, but now he can discuss.
Is it per wheel?
Yes, that is. That is the problem here is a little resources and a small country. Yeah.
No, still the vaccine is not available. Still the vaccine is not
but the
available.
people who are producing the vaccine, this is they have, because it is very
It should
important
be.
for
It
them.
should be in the, like, I think in the.
Okay.
Invention, actually. It's a very good invention and practical.
Yeah, but it is actually, yes, no. It's right. It's changing. I'm not looking at that exactly. What is the management and sophisticated management? Just I want to the general practitioner or the or anything one family medicine who has one patient with any abnormality, especially the babysitting. Okay, when he has the babysitting, he can find them easy. I know it is. He will refer here to the gynecologist. But at least he will know what is the proper step he has to do. Instead of saying, okay, you don't have anything, you can go, you are normal, okay, and
of course. It is very good invention, actually.
And counseling as well. Counseling also. Like it's quick.
Yeah.
The last lecture, yes. The next presenter is Professor Dr. Mohammed Jibreel, Professor of Obstetrics and Gynecology at Al-Azhar University, consultant IVF, AXI and Gender Determination Founder and Medical Director of Alden Bent Center for the treatment of delayed pregnancy and gender determination of the fetus. Dr. Mohammed, sorry. Can you hear us, doctor?
Multivitamins during pregnancy. My name is Dr. Mohammed Jibreel, Professor of Obstetrics and Gynecology at Al-Azhar University. My greeting for all of you, and I hope for grateful conference, inshallah. The time allowed for me is say 15 minutes, so I will give very important point about the multivitamins during pregnancy. All of us know that vitamin deficiency is one of the most important nutritional deficiency which occur during pregnancy and even before. And according to the Center of Disease and Control, 1 in every 6 women are vitamin deficient from low dietary intake, and prenatal supplementation is the one way which can help to achieve proper nutrient. Most healthcare providers prescribe a prenatal vitamin and mineral supplement because many women don't meet their nutritional requirement during the first trimester, especially iron and folic acid. There is a growing evidence support an important role for the intrauterine environment in shaping fetal development and subsequent child health and disease risk. There is a new concept which is named fetal programming. Fetal programming is a theory which suggests that the environment surrounding the fetus during its developmental phase play a seminal role in determining its disease risk during the later stages of life. Fetal programming can occur if the mother is vitamin deficient, so the blood will go for the important structures and the other organs will be deprived from the blood, leading to intrauterine growth retardation, and fetal programming will lead to suboptimal in utero growth of the fetus, leading to most of the adulthood diseases like diabetes, obesity, type 2 diabetes due to exhaustion of the beta cell of the pancreas, coronary heart disease, hypertension, renal failure later on. Many adulthood disease is originated due to fetal programming if the mother is prone to nutritional deficiency during her pregnancy. Even the brain can undergo fetal programming, leading to some diseases like dementia, like Alzheimer, like schizophrenia. It is recorded some of the diseases may occur in the adulthood due to fetal programming and decreased nutrition during pregnancy. As all of us know that the iron deficiency is the most common nutritional deficiency and is the major cause of iron deficiency anemia in pregnancy. And the World Health Organization reported anemia to occur in 18% in pregnant women in developed countries and may reach to 70% in the underdeveloped countries. Keep in mind, most of these women are anemic before conception. And it is estimated that 2 billion of people all over the world have been anemic. More than 30% of the fertile women in developed countries don't have adequate iron stores, and iron deficiency is the most common cause of antepartum, and don't forget postpartum anemia, which is a sequel of antepartum anemia and should be treated also. Remember that oral iron is the mainstay of treatment for iron deficiency. And intravenous iron may be indicated if oral iron treatment is unsuccessful in some cases. Most of women with iron deficiency suffering from fatigue, exhaustion, weakness, less energy, cardiovascular symptoms like palpitations, pallor, and tachycardia, hypotension, and in chronic cases, cardiac hypertrophy. Anemia may lead to maternal sequelae like blood loss, maternal cardiovascular strain, reduced physical and mental performance, reduced peripheral blood reserve, increased risk for peripheral blood, for peripartal blood transfusion, insufficient milk syndrome postpartum, in postpartum anemia. This is the effect of anemia on the mother. Also, some fetal risk can occur starting from intrauterine growth retardation, premature delivery, intrauterine fetal death, increased risk of infection, and as I mentioned before, fetal programming, which lead to adulthood diseases like hypertension, diabetes, obesity, and so on. This is the lab parameters for diagnosis of iron deficiency and anemia. We have to differentiate between iron deficiency only, iron deficiency anemia, and full-blown picture of iron deficiency anemia. The condition start by iron deficiency only. So in this case, we will found iron to be low only, but all parameters to be normal. But in case of iron deficiency anemia, hemoglobin will be decreased. Iron deficiency diagnosed when the serum ferritin level of 30 microgram per liter is commonly used to diagnose iron deficiency during pregnancy. I want to focus on postpartum anemia. If antepartum anemia affect over a third of pregnant women globally and is associated with major maternal and perinatal morbidity, including peripartum transfusion, maternal death, maternal infection, preterm birth, and neurodevelopmental disorder among offspring. Postpartum anemia affect up to 80% of women in low-income and rural populations, and up to 50% of women in Europe and the United States, and is associated with postpartum depression, fatigue, impaired cognition, and altered maternal-infant bonding. Remember, additional iron is needed to expand the maternal red blood volume by 20 to 30%, and iron is also required for fetal and placental tissue production. Hemoglobin less than 11 gram per deciliter or hematocrit below 33% in the first or third trimester indicates anemia. Hemoglobin less than 10.5 gram per deciliter or hematocrit below 32% in the second trimester also indicates anemia. Iron supplementation is often prescribed during pregnancy because of the 20 to 30% expanded maternal red cell mass, as well as for fetal and placental tissue production. Iron supplement can cause gastrointestinal side effects, such as constipation. Prenatal care providers generally recommend daily iron supplementation with 30 milligrams of elemental iron in the form of simple salt, beginning around the 12th week of pregnancy for women who have normal preconception hemoglobin measure. Women with severe iron deficiency, those who cannot tolerate oral iron, or those with malabsorption syndrome, parenteral iron can be used. Parenteral iron is especially valuable for increasing hemoglobin level faster than oral iron. But nowadays, there is special formulations like the so-called nano medicine. And there is some formulations in the market which compared to IV in the increasing hemoglobin compared to IV exactly. I mean lysosomal carriage system in some publications equal IV in restoring hemoglobin level and iron stores. Don't forget lactoferrin as a treatment of iron deficiency anemia. Lactoferrin is present in breast milk and cow milk, and it is one of the important tools for treatment of iron deficiency anemia. It has less side effect on the GIT, and it has many functions like antibacterial, antiviral, antifungal, and even anti-cancerous activity. Also, most of us know that during the COVID-19 era, lactoferrin was used in many protocols as a supplement for prevention of COVID-19. And most of the publications said that it is a very useful supplement for such cases. As I mentioned, it has also immune functions. It has anti-inflammatory and immune modulator functions also. So one of the most important tools for treatment of iron deficiency anemia is lactoferrin. One of the most important supplement during pregnancy and must be offered for the woman at least 3 months before pregnancy is the folic acid. As all of us know that folic acid is one of the most important supplement to prevent neural tube defect. Neural tube defect, either closed neural tube defect or open tubal tube defect, one of the most common fetal anomalies, and they can be decreased significantly when we are using folic acid. This led to the UK government has mandatory folic acid fortification will help to decrease anencephaly and other neonatal tube defect. The daily recommended intake for folic acid during the childbearing age is 40 microgram per day for pregnant women. But women who has a high risk for neural tube defect, like epileptic patient on anti-epileptic drugs, or patient with previous history of neural tube defect should receive 4 milligram per day and even before conception to prevent neural tube defect. Neural tube defect is occur very, very early in pregnancy because the neural tube is formed in the very early days of fetal life. So the folate should be prescribed before pregnancy, before the neural tube to fuse. In 1970s, reduction in the serum concentration of several vitamins like folate are noted in mother pregnant with neural tube fetuses. This stimulated a UK-based intervention trial of a multivitamin supplement containing 36 milligram folic acid during the periconceptional period, several weeks prior to conception, and continued until 12th week of pregnancy. This is the sequence. This is a picture for neural tube defect. It is really, it's equally will cause the child to be handicapped. So prevention is better than cure, and a very useful folic acid supplement will reduce significantly this kind of fetal anomalies. This is the picture for anencephaly. You know, all of us, that anencephaly is incompatible with life. One of the most important multivitamins which can be given during pregnancy is the antioxidant. And in most of the publications, oxidative stress is one of the causes of many diseases. So antioxidant plays a pivotal role in the regulation of fetal growth and the development, and decrease the future risk of adult diseases. Recent evidence indicates that maternal oxidative stress during pregnancy plays an important role in the pathophysiology of low birth outcome. Subsequently, some descriptive studies have investigated the associations between maternal or cord serum levels of antioxidant vitamins such as vitamin A. Vitamin A should be should be given as recommended with a low dose because it is teratogenic if given in high dose. However, to our knowledge, the influence of antioxidant vitamin levels during pregnancy on the child's long-term intelligence, cognitive, and behavioral development has not been well established. A variety of studies have shown that cognitive development may be influenced by many factors, including family conditions and early nutritional status. This as regards the antioxidant, which should be given, which should be supplemented during pregnancy, as it has a very important role for many conditions with oxidative stress. One of the most important supplements during pregnancy is the vitamin D. Nowadays, most of the lab results of vitamin D came with low vitamin D, and it is attributed to many reasons. No exposure to some light. Some people and some the pollutions in the air prevent vitamin D formation in the skin. So pregnant women and newborns have been described as a population at increased risk of vitamin D deficiency. According to a systematic review, the prevalence of vitamin D deficiency defined by the author as serum 25 hydroxy vitamin D less than 20 nanogram per milli was reported as 64% of women from the Americans, 57% from the Europe, 46% from the Eastern Mediterranean, 87% for the South Asia, and 83% from the Western Pacific. So this means that vitamin D deficiency is very prevalent in most of the countries. The high prevalence of maternal vitamin D deficiency may be related to changes in lifestyle, sun exposure, and dietary intake.
Dr. Mohammed, you have 1 minute left for your presentation. Excuse me. You have 1 minute left for your presentation. Thank you.
Can provide calcium to the fetus with vitamin D. Furthermore, women who have greater skin melanin immigrant, particularly if immigrated from one sunny climate and veiled or covered, are considered at particular high risk for deficiency, as endogenous production of vitamin D from ultraviolet exposure is limited. Just I wanted to mention something. Most of us measure vitamin D3. Just vitamin D3 is indirect reflects the active form 125 dihydroxycalciferol, which is the active one in the body. So we indirectly, vitamin D3 indirectly reflect the vitamin D status in the body. Because the fetus is dependent on maternal vitamin D deficiency may lead to consequences for maternal health as well as fetal and infant growth and development. Given the high rates throughout the world, vitamin D deficiency is a potential public health problem. During pregnancy, vitamin D is also critically important for fetal growth and development, as well as for regulation of genes associated with normal implantation and angiogenesis. Vitamin D supplementation is advised for women who are strict vegetarians, those with limited exposure to sunlight, and those from minority populations with dark and black skin. To evaluate vitamin D levels during a periconceptional or prenatal visit, serum 25 hydroxy vitamin D levels may be evaluated. Sufficient levels of vitamin D during pregnancy may be protective against offspring's development of multiple sclerosis. There is a recent publication about the link between vitamin D and the multiple sclerosis later in the life. Also, in the COVID-19 era, all of us know that vitamin D deficient patients have prone to COVID-19 disease and SARS-CoV-2 infection. So, vitamin D level above 40 seems to decrease the infection rate, decrease COVID-19 in general. Vitamin D supplementation is often required during pregnancy, in particular for those with less exposure of vitamin D, of sun rays. One of the most important supplements during pregnancy is the omega-3 fatty acids. And the US FDA recommend that pregnant women consume 20 to 30 milligrams of omega-3, which can be achieved by consuming 1 to 2 servings of fish per week. However, the average pregnant or lactating woman consumes only 52 milligrams per day of docosahexaenoic acid and 20 milligrams per day for omega-3 fatty acids. Omega-3 fatty acids and the vitamin co-supplementation may have a positive effect on metabolic status in gestational diabetes. Also, it is known that omega-3, one of the preventive measure for preterm labor, one of the most important measures that decrease the incidence of preterm labor is the use of omega-3 fatty acid. Fish oil supplementation during pregnancy is protective against asthma and wheeze in the offspring. This is one of the most positive beneficial effect of omega-3 for the newborn. Prenatal supplementation with vitamin D3 and fish oil, derived fatty acids, such as omega-3, have recently been shown to reduce asthma and recurrent wheeze in children. One of the most important supplements also during the pregnancy is the calcium. The daily required intake for calcium in non-pregnant and pregnant women between 19 to 50 years of age is 1,000 milligrams per day, and it is 1,300 milligrams per day for females 9 to 19 years of age. Large quantities of calcium are essential for the development of the fetal skeleton, fetal tissues, and hormonal adaptations during pregnancy. Evidence has also shown that calcium supplementation reduces the risk of developing hypertension during pregnancy, but only in women who didn't have adequate calcium intake prior to supplementation. All of us know that calcium is one of the measures that decrease hypertensive disorder with pregnancy. This is the daily required intake, as I mentioned before. Calcium has long been suspected as a nutrient related to preeclampsia, as I mentioned before, and randomized controlled trials have confirmed that calcium supplementation reduces the risk of preeclampsia by 55% to 62%, depending on the dose. However, most studies begin mid-pregnancy and have been rated as low quality. All of us know that the aspirin is the most important preventive measure that decrease the incidence of preeclampsia, low-dose aspirin. From this evidence, the World Health Organization recommends calcium supplementation during pregnancy, 1.5 to 2 grams per day, for the prevention of preeclampsia in populations with a low dietary intake of calcium. Also, the WHO recommendation is to begin supplementation as early as possible. Also, there is no evidence on the best timing of initiation because calcium supplementation starting after the first trimester has been shown to reduce the severity of preeclampsia. It was suggested that giving calcium in the periconceptional period would have a greater impact on prevention. A recent randomized controlled trial was conducted in 3 countries among women who developed preeclampsia or eclampsia in their previous pregnancy. This trial was tested the effect of calcium supplementation given from the pre-pregnancy through 20 weeks gestation. Didn't find any impact or risk of recurrent preeclampsia. Although sub-analysis showed a benefit of calcium among women with high supplement compliance, and other trials testing supplementation in this early time frame are lacking. The WHO recommends pre-pregnancy calcium supplementation only in the context of rigorous research for prevention of preeclampsia. So calcium supplementation appears to reduce the occurrence of preterm delivery and preeclampsia in hernivorous women beyond the age of 35. One of the most important zinc, also in the era of COVID-19, zinc was one of the most important supplement for prevention of this disease. More than 100 enzymes require zinc, and the maternal zinc deficiency can lead to prolonged labor, intrauterine growth restriction, teratogenesis, and embryonic or fetal death. The daily required intake for pregnant women is 11 milligrams per day and may be higher for vegetarians or vegetarians since phytates from whole grains and beans bind with zinc and can reduce the absorption. By the way, zinc is one of the most important supplements for men, and it is known that zinc is one of the most important preventive measures for prostatic hyperplasia and prostatic cancer. Zinc, especially in men, is very important for this indication. Vitamin C and E and other antioxidants has many beneficial and positive effects in many stress factors. Because the time is allowed for me is 15 minutes only, so I will not exceed the time. And I wanted to focus on 2 important items: iron, folic acids, calcium, and other supplement is very important for pregnant women, and we should improve the outcome by supplement these very essential, important supplement during pregnancy and even before conception, just to get a healthy child with very good outcome. Thank you very much. And any question, I am ready. Thank you very much.
So this is the last presentation in day 1. And on behalf of the organizers, I would like to thank you for attending the Congress today. And we expect to meet tomorrow, day 2 at 9 o'clock in the morning. Thank you again for all participants online and on site. And we invite you for the lunch in the other hall. If any question is there, you can always upload it in the Q&A and the speakers can answer it later on. Thank you very much.